Pediatrics forces you to master one skill that separates average from excellent Step 2 scores. I used to struggle with why the same disease looked completely different across question. Then I unlocked the secret. Peds isn't about learning pediatric diseases, it's about mastering how presentation changes with development. I'm sharing exclusive footage from our paid course. Actual coaching sessions revealing how students went from memorizing facts to thinking like top scorers. These aren't just pediatric principles, they're the age-based reasoning patterns that appear throughout Step 2. See how mastering this approach transforms every patient scenario into a question you can confidently solve. To start, I'm going to walk you through some of the highest yield concepts that affect not just pediatrics, but it will also help every single other system and specialty that you're studying for Step 2 and your other shelf exams. One of the topics that we're going to cover in this is endocrinology. And so what I want to present to you is a framework for understanding virtually any endocrinology condition and to also use this to predict the labs. Now, I know that this is one of the things that a lot of people struggle with, for example, like primary adrenal insufficiency versus secondary adrenal insufficiency, like which condition has high ACTH, which is hypotension, right? Most people are just memorizing these things, but if you understand the principle, now you can use this to explain not just one particular fact, but also use it to understand and learn lots of other endocrinology conditions faster, remember it better, and get more questions correct on the exam. So basically, the framework is you want to understand the difference between primary, secondary, and tertiary endocrine disorders. So a primary endocrine disorder, what does it mean? It's basically a disorder of the end organ itself. So for example, if I've got primary hypothyroidism, what that means is that the thyroid gland itself is not producing enough thyroid because there's a problem with the thyroid gland, right? As opposed to, so for example, let's say that someone has primary hypothyroidism. So what exactly does that mean? That means that there's hypothyroidism, meaning there's low thyroid hormone levels where you're producing low thyroid hormone because of dysfunction in the thyroid gland itself. As opposed to secondary and tertiary endocrine disorders, where secondary is one above the thyroid, right? So the pituitary is the thing that feeds into the thyroid gland. And so secondary hypothyroidism would be a problem with the pituitary. And then tertiary is one step removed from that, one step upstream of that, which means that there would be a problem of the hypothalamus. So for example, in hypothyroidism, or for just general understanding of endocrine disorders, you've got primary disorders, which is of the end organ itself, like the thyroid or adrenals. Secondary, which is a problem of the upstream organ, which is the pituitary, right? So in this case, if I had a problem in the pituitary, I'd have too little TSH, and too little TSH means that there would be too little stimulation of the thyroid gland. If there's too little stimulation of the thyroid gland, right, ultimately I will still have too little thyroid hormone. But again, this is coming because of a problem in the pituitary. And then finally, tertiary would be a problem of the hypothalamus. Now, we're going to go much more in depth in this in the lesson, but this is just a conceptual overview that you can use to understand the general process for understanding pretty much every single or almost every single endocrine disorder. The next thing that we're going to cover in this lesson is LFTs, and specifically Gilbert and bilirubin. So one of the most common things that I see people struggle with is understanding labs and in particular LFTs. And so we're going to use Gilbert syndrome as a way to not only understand a pediatric condition, also in addition to that, to help you understand LFTs at a deeper level. And so bilirubin, as you may know, comes as a breakdown product of heme, and particularly the porphyrin ring that is heme. So the porphyrin ring is nonpolar, and so it would make total sense then that the breakdown product of something that's nonpolar, right, which is the porphyrin ring, would also be nonpolar, right, which is bilirubin. And so this is the reason why bilirubin has to be conjugated, right? Because if something is nonpolar, then it can cross cell membranes. And so you conjugate something onto it, in this case, glucuronic acid, which is relatively polar. And what that allows for is that the bilirubin will stay within the lumen of the GI tract and in the biliary system. Porphyrin rings are really interesting. So what you're going to learn later more is that bilirubin is a breakdown product of one form of porphyrin ring, which is heme, but also myeloperoxidase is also something that contains heme, which is also a porphyrin ring, which is why pus is greenish, kind of yellowish, right? This is because, again, you've got this system with lots of conjugated double bonds, and so because of this, it absorbs visible light, and because of this, it means that it has a color. Chlorophyll, also same thing, right? So chlorophyll is green, and so when it breaks down, it also creates a colored compound, right? Because it is also a porphyrin ring with lots of conjugated double bonds. And so that's why in the fall, you get all of the nice colors in the leaves. And so Gilbert syndrome is ultimately a problem where you cannot conjugate bilirubin nearly as effectively. And so as a consequence of this, you're going to get unconjugated hyperbilirubinemia, particularly during times of stress or fasting or illness, because you're going to have a decrease in the amount of conjugation that you're able to do. So this is just a brief preview of some of the lectures that you're going to see. There's also another lecture that you're going to learn about more later, which is going to be about genetics, which is a common condition that people struggle with for their shelf exams and for step 2. So understanding these principles can help you not just do better on your shelf exams, but also for step 2 and other concepts. Today, we are going to transition to talking about GI stuff. And so I'm going to read this vignette slowly as I would in the real world. And because again, slow is fast. And then we'll have you do the pathophysiologic chronology. So a 15-year-old boy comes to his physician for nausea and vomiting for the past 2 days after a school potluck. Several of his classmates and teachers reported similar symptoms. Temperature is 37. Blood pressure is 120/80, and pulse is 72. On exam, there is mild scleral icterus. Abdomen is soft, non-tender, and mildly distended. Labs are significant for T-bili 3.5, direct bili 0.3, alkaline phosphatase 40, AST 20, ALT 21. What is the pathophysiologic chronology? What is the significance of the total versus the direct bilirubin? Is the alkaline phosphatase normal? And why would that make sense? And what color would his urine be? So I'm going to put this in the Google Doc, and then I will have you guys do that. Physiologic chronology. So this is Gilbert. So in other words, if you said he was born healthy, that's not technically true. So he was born with the UDP glucuronidase activity down for whatever reason. And so he was asymptomatic until he had a GI illness. When that happened, he had a decrease in the conjugation of his bilirubin, which led to an isolated increase in his unconjugated bilirubin. So that was why his total bilirubin was high, but his direct, in other words, his conjugated was low. So if the idea of conjugated versus unconjugated or direct and indirect and all this stuff confuses you, this is the lesson for you. So a lot of people have been asking about additional practice with these concepts and other some of the more common concepts on the USMLEs. We actually have a free 14-day video series that breaks down even more some of these topics, and we include some test-taking strategies that we use to help some students who have gone literally from failing to 250s or even 260 plus on step 1 or even step 2. So be sure to click on the link in the description below if you want to check it out. Also, if you're confused about AST and ALT and all that stuff, this is it, whereas what we're going to talk about. So summary of key concepts. So as a reminder, bilirubin, right, is a breakdown product of heme, which is a porphyrin ring. Porphyrin rings are nonpolar. So again, I'll repeat all this stuff later, but this is just the overview. So when you break down heme, you get bilirubin, which is also nonpolar. This makes sense. Heme is nonpolar. When you break it down into bilirubin, bilirubin is also going to be nonpolar. Because it's nonpolar, if you want it to stay dissolved, or if you want it to not cross over and be absorbed by your GI tract, then you have to conjugate it. It happens to be conjugated with glucuronic acid by UDP glucuronidase, and that's what's deficient in porphyrin rings. Interestingly enough, so they are nonpolar, and they're nonpolar because they have a lot of conjugated double bonds. And so they absorb visible light, which means they are, for our purposes, they have color. So heme is red because it's a porphyrin ring, because it absorbs visible light because of all the conjugated double bonds. Or bilirubin is yellow because, again, it's also very nonpolar, has an alternating structure of double bonds with single bonds. Myeloperoxidase, so why pus is green, is because, again, neutrophils have myeloperoxidase, also based off of a porphyrin ring. Chlorophyll also is a porphyrin ring. That is why it's green, right? All of these things that have color in our world, many of these natural things are based on porphyrin rings. And because they have this conjugated double bond structure, right? Where you have double bond, single bond, double bond, single bond, double bond, single bond, double bond, single bond. That is why they have. That is why. It's cool. As we talked about, it's where you have decrease in UDP glucuronidase activity. It leads to an isolated, unconjugated, right? In other words, an indirect hyperbilirubinemia when you have periods of stress like this guy had. And then as a final reminder, we're going to talk about LFTs, but as a reminder that it's basically a misnomer. They are not actual tests of liver function, and we'll talk about why. All right, so we've got a lot of stuff. So let's start with Leah. So Leah, what is bilirubin? You just have to remember, you have to unmute yourself. There we go.
So bilirubin is a breakdown product of hemoglobin.
Actually, specifically, so what's the
Of
difference?
heme.
Of heme, yeah. What's the difference between heme
Yes,
and
sorry.
hemoglobin?
Heme, there are 4 heme molecules in a hemoglobin.
Good. Yeah, exactly. Hemoglobin is the protein, right, that contains the heme. Heme is the smaller molecule that actually binds to the oxygen. So, Fong, what organ does most of the bilirubin in your blood come from? And why would that make sense?
You mean liver?
Actually not. No. The bilirubin goes to your liver, but what makes the bilirubin, so to speak?
So the spleen?
Yeah, very good. So why would that make sense?
breakdown.
Yeah.
Mhm.
Yeah, because that's where your blood cells are broken down. Great. So bilirubin is a breakdown product of heme, right? So the spleen is where you're breaking down all that heme. So it makes sense. And so Satya, is heme water soluble or not water soluble, and why?
Heme has protoporphyrin and iron. I would think it's water soluble.
Let's look at the structure. So I included it here. So is this very polar or nonpolar?
It looks non-polar.
Very nonpolar, extremely nonpolar. You are correct. Yeah. So if it's nonpolar, is it
So-
going to be water soluble or not? Probably.
So it's not.
Yeah. It's not. It's very nonpolar, right? So you can just see, right? It's like, yeah, this is definitely not polar. Right. So in general, right? So they say likes dissolves likes. It's an easy way to remember it. So water is polar. Things that are not polar do not dissolve well in water. So porphyrin rings absorb visible light. Io, what color is heme when it's bound to oxygen, and why? It's just red. This is why your blood is red. Right?
Oh, gotcha.
It's hard to be put on the spot. This is good. It's good practice because oftentimes the questions are easier than you think. So yeah, so porphyrin rings absorb visible light. And so as do basically many things with conjugated double bonds. Fun fact, again, chlorophyll, which gives plants their green color, also is a porphyrin ring, which makes sense because porphyrin rings have a lot of conjugated double bonds. The conjugated double bond structure basically allows it to absorb light in the visible spectrum, oftentimes. So most things like dyes have a lot of conjugated double bonds, just in general. If you're interested. So Matan, what color is bilirubin and why?
Yellow color.
Yeah, it's like yellow. Yeah. Why is it colored and why is it not without color?
Well, it doesn't have oxygen bound to it, so that removes the darker reddish brown. I'm not sure exactly why it's yellow though.
Again, same thing. Sorry, I think I should rephrase these questions. Really, it's not why is it red or why is it yellow? It's why does it have color in the first place? It is color in the first place because again, bilirubin is the breakdown product of heme, right? Heme is colored, so it would make sense that if you break it down a little bit, that it would also still have color in it, right? Because again, both have many conjugated double bonds, and so they absorb light in the visible spectrum. You can see it. You can just see it here. You don't have to be a chemistry guru to see like double bond, single bond, double bond, single bond, double bond, single bond, double bond, right? Single bond, double bond. That is what a conjugated double bond is, right? We have an alternating structure, a double bond, single bond, double bond, single bond. So when you see that, you should think both A, nonpolar, and B, that it is going to absorb visible. Again, I'm trying to make this is like chemistry for MDs, right? This is very simple. So what color is poop, Moise? And why does it have color?
It's yellow or dark brown.
Yellow, brown. Yeah, brown. Yeah. Why does it have color?
I'm not sure.
Because again, so it's because it all comes from heme, right? So ultimately, it's all coming from heme. So
Right.
because you have bilirubin that's broken down into urobilinogen. The urobilinogen is broken down by so bacteria break bilirubin to urobilinogen, and from urobilinogen to stercobilin. So stercobilin is the brown thing. You can see it's very similar to bilirubin. It's extremely similar, and also has a lot of the conjugated double bonds, right? Double bond, single bond, double bond, single bond, double bond, single bond, double bond. Right? Cool, Nita. So what color is P and why?
It's yellow because it's a breakdown product of bilirubin or heme.
Yeah, exactly. And so it has a lot of what?
Broken up heme.
Well, it's a lot of conjugated double bonds, right? So the urobilinogen, right? Just like for poop, just like making stercobilin. But so some of the urobilinogen is reabsorbed into the bloodstream. Some of that's filtered. And then in air, I think with oxygen, it oxidizes, presumably either from just the oxygen that's in the urine or in your blood. And so that becomes urobilin, and that is yellow. But again, you can see it's just the same thing. Like they all look very similar. So it would make sense that all of these things come from the same thing, right? Heme, and that they would be colored. Cool. What important immune system enzyme uses a porphyrin ring, and what color is it? Myeloperoxidase. So in the respiratory burst, right, it actually contains heme, which is interesting, right? So it also contains a porphyrin ring. But Jana, pneumonia. What question can you ask to help you differentiate between bacterial and viral pneumonia and why.
Maybe you could ask them the color of their sputum.
Yeah, you can. And that is actually what people do, what you're supposed to do. You say, do you cough? Is it productive? And then you ask, what color is it? So what color would make you concerned for bacterial pneumonia?
Green?
Yeah, green or yellow. What color would make you less concerned for bacterial pneumonia and think more viral pneumonia?
Maybe like clear, like normal color.
Clear. Yeah, exactly. Perfect. So you say, if there is sputum, what color is it? If it's green or yellow, that would indicate neutrophil presence. Since when the neutrophils break down, they're going to release their myeloperoxidase, which again contains heme. The heme, again, is a porphyrin ring, right? So it absorbs visible light, right? So if the heme breaks down a little bit, then you can actually basically get bilirubin. I'm pretty sure that's where the yellow comes from if you've got like yellow sputum. Cool? Yeah, all these things. Who knew? So Deb, so abuse, right? This is something that you guys should all, right, that are going to go into patient-facing specialties should be aware of. So if you suspect physical abuse, very few abusees will say, oh yeah, like I'm being abused. Oftentimes the way that medical providers will hear it is, oh yeah, I'm accident prone, or I fell down the stairs or whatever. What physical evidence can you look for that will help you confirm that it wasn't just they fell down the stairs one time, that it's actually like multiple episodes of abuse?
The location?
Yes, location is definitely one of them. So what about, this is not what I was looking for, but you're right. That is one thing. And that's something that shows up sometimes.
Sorry, what's your question?
So location is one of them, right? So you can get you have defensive injuries, right? So like usually it's their forearm, but what about the bruises themselves? How are they going to look?
Could it be because like frequent bruising and frequent?
Not just frequent bruising, but the age of the bruises. So remember, if a bruise is just bleeding into your skin. So when you bleed into your skin, the breakdown of that blood is going to follow a very stereotyped process, right? Meaning if I have 5 bruises all at the same time, they should all look the same as they progress. So if you just fell down the stairs one time and got a bunch of bruises, then all of your bruises would be the same color. They'd all be red. However, the thing that you should look for in physical abuse is look at the age of all of the bruises. In other words, older bruises are going to have more bilirubin in them because the heme has had more time to break down into bilirubin, right? Like, sad that we have to like think about this, but there is a scientific basis. Cool?
Very cool.
Yeah. So if the age of the bruises don't match, they couldn't have occurred during the same incident. So if some of them are red and some of them are reddish yellow, because the heme is broken down into bilirubin, they couldn't have all happened at the same time. I remember once my grandmother-in-law, my wife's grandmother, there was like a problem in the hospital and she fell. And so you can do this also in radiology. So you can look at the age of, because you can see, because like fresh bleeding is going to be more dense on a CT. So it'll look more dense. You can actually look at the age of, you can estimate the age of like different lesions. Like if someone fell down once or she fell, they were moving her and she fell from a very high height because she was getting like a scan or something. And so we were looking at the CT scan and you could tell that there had been like probably multiple falls because you could see that some of the bleeding was more dense, like some of the areas of blood were more dense than others.
Alec, I have a question.
Yeah.
On one of I'm doing Kaplan now. One of the questions was basically comparing an epidural hematoma and I think it was either subarachnoid or subdural. But the pictures in the description, one of them was a really bright white, which was the epidural hematoma, and the other one was a darker color. Does it make a difference where
that's actually exactly what I was just talking about. Yeah. So an epidural hematoma is going to present more quickly because it's an arterial bleed. So the blood is going to be more dense because it's going to be fresh blood, be more iron there. So remember, if you remember from the cardio lecture,
would be venous blood.
Yeah. Whereas a subdural hematoma is typically like subacute. And so there is much more time for that blood to like the heme to break down and the iron to be resorbed. And so it will not look as dense.
I got you.
Cool? Yeah, same idea.
Right, I totally missed that.
That's a great question.
I wanted to know, it wouldn't matter the size of the bruise in terms of the color. If someone bruised themselves in different areas.
Yeah, if I had a gigantic
all-
bruise, the color should be the same. It's the age that will tell what the color should be.
Okay.
So we are on, I think, Suja. So Suja, is unconjugated bilirubin water soluble or not, and why?
It is not because it's non-polar.
Yeah, it's super nonpolar, right? Yeah. So again, it makes sense. Heme is nonpolar, bilirubin's nonpolar. So it makes sense that they would both be poorly water soluble. And so Feluke, so unconjugated bilirubin, will this be absorbed by the GI tract? Why or why not? You can, yeah, because again, it's non-polar. So generally, non-polar things cross pretty well. This is why like urobilinogen, which again is a breakdown product of bilirubin, can be absorbed by the GI tract, and why it can end up in your bloodstream and ultimately your urine.
Thank you. I didn't know.
Yeah. So if we look at what does conjugation of bilirubin do? Like, why would we do that? Why would we want to conjugate it?
It's to excrete it
Yeah. So why? What about conjugation allows you to excrete it? You're right. Absolutely. But why?
because we want to get rid of it.
Well, true. That's the teleologic thing. But like physically, what do you conjugate onto it? Ty, what do you think? Why does the conjugation of bilirubin allow you to excrete it?
Because it's water soluble, it's able to be filtered out by the nephron.
True, but unrelated. You are correct. But we do not conjugate it so that we can pee it out. We conjugate it so that we can poop it out.
Could I give it a try?
Please.
So if unconjugated bilirubin is absorbed easily, then is conjugated bilirubin not absorbed easily, and that's why it could be excreted easily?
Boom. Yeah, because you conjugate it with something that's polar, right? What's that? So glucuronic acid, right? The acid itself probably gives part of it away, but so it's pretty polar. So you conjugate it with something that's polar, so that way it doesn't get absorbed by your GI tract, and therefore can stay in your GI tract and you can poop it out. Good. All right, so let's talk about some of these labs. Let's try and dig into this. So Claudia, so what does it mean? What does direct bilirubin actually refer to? So you've got total bilirubin and direct bilirubin. So what does it mean to say direct bilirubin?
Is that conjugated bilirubin?
That is conjugated. It refers to the conjugated bilirubin. So technically, if you're curious, just if you're curious. So the way that they measure it is they add what's called a diazo reagent, which basically goes, so if you have bilirubin, there's going to be the water soluble kind and the not water soluble. So it's going to split like oil and water. So the diazo reagent is going to go, it happens to be more hydrophilic. So it's going to go to the hydrophilic part, which is the direct bilirubin, right? Because the whole point of conjugating it is to make it water soluble. So it goes to the water portion of it. And so that's why, and it reacts with it and makes it colored. And so that's basically the reaction is what you're measuring. So it's called direct bilirubin because that's what you're actually measuring. That's the thing that you're actually measuring. They call it indirect bilirubin because it's the thing that you're only indirectly measuring. Kind of cool, yeah. So Saba, what does total bilirubin refer to?
Total bilirubin is both conjugated and unconjugated. So direct and indirect together.
Perfect. I meant to say Saba though, but that is correct. So Saba, what do you think? Indirect bilirubin. Use what it is to explain how you would calculate it.
I think you would do the total bilirubin minus the direct bilirubin to calculate the indirect one.
Perfect. Yeah, that's exactly right. So the indirect is the unconjugated, right? So it isn't directly measured, right? Hence the name indirect. So you can calculate it basically by saying it's the total minus the direct. That's it. So Saba, what is elevated? Is it the direct bilirubin or the indirect bilirubin that's more elevated here?
I think it's the indirect.
Yeah, definitely. Because 3.5 minus 0.3 means that your indirect, right, your unconjugated bilirubin would be 3.2. So almost all of this is indirect. All right. So Miriam, where does conjugation happen? In what organ?
In the liver.
Boom. And so the biliary system is split into two parts, the intrahepatic and the extrahepatic. So Miriam D, what would be considered part of the intrahepatic biliary system?
I know there's like the main vein and then there's like all these cells right
It's
beside
okay.
it.
I didn't know this. I had to look it up. It's the right and left hepatic ducts. So Rosa, where's the extrahepatic biliary system?
It would be whatever is outside the liver.
Yeah, basically, everything that's not the right duct, the common bile ducts. Great. So this is just something that's interesting, but do you happen to know, Shama, do you know what's the difference between PBC, primary biliary cholangitis, which used to be called primary biliary cirrhosis, but they changed it. So PBC, primary biliary cholangitis, versus primary sclerosing cholangitis. Do you happen to know what the
I
difference?
believe so. Primary biliary cholangitis is what used to be called like primary biliary cirrhosis, and it's autoimmune in middle-aged women, and it's intrahepatic like fibrosis, like duct fibrosis, compared to like primary sclerosing cholangitis would be extrahepatic like fibrosis.
Almost, very close. That was exactly
Okay.
right, except that PSC is actually both extra and intrahepatic. Cool. So PBC is intrahepatic only, and then PSC is basically both. But yeah, that was good. All right, Leah. So unconjugated bilirubin. So use whether it is water soluble or not to explain whether an unconjugated hyperbilirubinemia would lead to dark urine from a. So if you have unconjugated bilirubin in your blood.
Yes, it is because it's The unconjugated version is not water soluble, is what we talked about.
True, but why would it end up in your urine then? Because isn't your urine water?
So why would it go to your urine?
It doesn't actually. That's the punchline.
Okay.
It doesn't lead to dark urine. I love the thought process, but yeah. So it's poorly water soluble, and because of so I want you to tell me why it would not lead to dark urine, because your reasoning was correct. It was just the final step.
So we said it's not water soluble. So then it is not going to be excreted in the urine. So it's going to stay in the blood.
Perfect. Yeah, because it stays bound to albumin. Most nonpolar things in your blood are bound to albumin, like just in general. Yeah, bilirubin being one of them. Or if you remember, like from biochemistry, right? Like free fatty acids basically bind to bilirubin. That's how they're transported in your blood. But yeah, so it doesn't. In other words, it doesn't end up in your urine. It stays bound to albumin. So how about Fong? So Fong, would a conjugated hyperbilirubinemia lead to dark urine or not? Why?
Yes,
It would. Good. Why?
because it's water soluble and it secretes from the liver cell and to the blood and get to the urine.
Yeah, exactly. So another way that you can differentiate between a direct and indirect hyperbilirubinemia on questions and in life is look at the color of the urine. Tea-colored urine or dark urine, it tells you that there's conjugated bilirubin, usually. Satya. So if you had a complete blockage of the common bile duct, what color would the stool be and why?
The stool would be pale because there is no bile coming in and
Yeah, exactly. Specifically, there'd be no, bilirubin coming in. So if there's no bilirubin, there's no urobilinogen. There's no urobilinogen, there's no stercobilin.
Sterco.
And so there's nothing that's going to give the stool the brown color. So classically, they say like clay colored.
yes.
So yeah. Boom. Isn't that cool? I know what some of you guys were thinking at the beginning of this. You guys were like, oh my God, are we really going to be talking about porphyrin rings? Really? And he said that this was going to be step 2 related. So just by understanding that one principle, you can explain so much. The color of bruises, like how cholestatic, like how cholestasis is going to present, the color, like why you ask the color of sputum, why pus is green and yellow, right? All that stuff. So Io, if you had a complete blockage of the CBD, the common bile duct, what color would your urine be and why?
It would still be dark red in color. So it makes it's blocked. Is there a way it could find its way into the serum
It does. It does. Yes, it does. Yep.
and the filter through the kidney? It would be dark red.
Dark. Not necessarily red. Remember, because it's bilirubin, not heme.
Dark yellow?
Yeah, just like dark yellow. Yeah. Just
Yeah.
like normal color, just really dark.
Remember.
Exactly. Because again, it's because think, and it's because you have conjugated bilirubin there. It's not the heme. So hemolysis can give you, right, like red blood or red. Myoglobinuria can give you red urine because the heme is still red. So the heme will make your urine turn red. And by the point that it's gotten to the common bile duct, you've got unconjugated bilirubin, goes through liver, gets conjugated, then goes into your common bile duct. So if this is blocked, then all that conjugated bilirubin is going to back up into your liver and then enter your bloodstream. And so it's the bilirubin that's getting into your blood. And so that, because it's conjugated, as you pointed out, stays soluble in the serum. So that will be able to be filtered through the kidneys because it's not bound to albumin. And so that will enter your urine and it will just make the urine dark yellow. Cool?
Yes.
Yeah. Matan. So what enzyme performs conjugation of bilirubin?
It's that one with the long name.
It is.
UG. There's 2 of them. Oh, there it is. UDP. Am I right there?
So it's UDP, glucuronal transferase, right? So let's just break that down. So it uses UDP, right? So UDP is basically just the carrier molecule. So that's not really the important part for MD purposes. This is not the important part. The important part is the glucuronal part. So transferase just means it's transferring it. Glucuronal is the important part. So it's glucuronic acid. So I was just curious, so I looked up the structure. But yeah, so this is the glucuronic acid, this right here. And so what ends up happening is the bilirubin will bind to this right here, to this cover right here. So again, all you need to know with this is that this is pretty polar, right? This is a carboxylic acid. There's a bunch of hydroxyl groups here, but yeah, this is pretty polar, right? This looks pretty similar to a sugar, basically. This is a pretty similar structure to a sugar, right? So pretty polar. So this is it's the same thing, right? Just written differently. And so this is bilirubin, right? So bilirubin, which is very nonpolar, now has bound to this polar thing. And by binding to this polar thing, it is going to make it polar. All right. So great. So Gilbert, what effect does stress have on UDP glucuronal transferase activity? So Nita, what do you think?
I'm not sure. I guess it would decrease the activity of the enzyme.
Yeah,
Not sure.
good. That would make total sense, right? Why would it make, So I spent a long time looking. I was trying to find some really great principle that was like, oh, fasting or stress like always decreases liver enzyme activity, but it's not like that. It really is quite complicated. Yeah, this is just one of those facts you have to either accept or memorize. But yeah, so this is, but again, remember, Gilbert always happens, like the classic one is like some poor medical student that's stressed and doesn't eat because they're cramming for a test or something, and then their eyes turn yellow because they've got an unconjugated hyperbilirubinemia because their UDP glucuronoltransferase activity goes down. So, but yeah. So Gianna, so now use the genetic basis of Gilbert syndrome to explain what you would see on the liver function tests. What abnormalities would you see?
So I think as we discussed, the genetic basis was that it decreases the ability for bilirubin to become conjugated. So based on that, and we said that the liver is the organ that does the conjugation, right? Maybe you would have decreased liver function, but I feel like
So we're going to talk about liver function tests next, but what if I should ask, what effect does this have on bilirubin? Total bilirubin, your direct and your indirect B.
So your direct would be lower because you can't conjugate it. Your indirect would probably be higher because it accumulates because it can't become direct. And then your total, would it be the same?
Usually higher, but I guess in theory, maybe it could be, yeah, depending on when you catch it. But if they're presenting, presumably it's higher. So in order to see jaundice, I think you have to have a bilirubin of at least 2.5. Yeah, it is. If they're coming in, it's because they're symptomatic. So yeah, it would be high.
Right.
Yeah, so good. So UDP glucuronoltransferase activity is low. When they're stressed, it gets even lower. And so they can't conjugate bilirubin well. And so they get an isolated unconjugated hyperbilirubinemia. Great. So let's go through some labs. So Deb, so in our Gilbert patient, can you explain the bilirubin labs? So again, T-bili was 3.5, D-bili, direct bili was 0.3.
So the lab finding is indirect hyperbilirubinemia is compatible with isolated unconjugated hyperbilirubinemia in
Yeah, perfect. Yeah, so problem with bilirubin conjugation, more unconjugated, so T-bili is up. However, because of the poor conjugation, your direct bili is not elevated, as Jenna pointed out. So good. And as you also pointed out, it's an unconjugated hyperbilirubinemia. Great. So the last part of this discussion is going to be about liver enzymes, and I wanted to talk about this in our first lecture because it's in all of GI is talking about the liver enzymes. So we're just going to go through this and we're going to make sense of it. The Sujith, what does LFT stand for?
Liver function test.
Great. And I put this in quotes, right? Because do you happen to know, Faluki, what's included in the LFTs? The standard LFTs? Like the normal, there's 4 things.
Alkaline phosphatase, SGPT.
So bilirubin's one. So T-bili and direct, or the direct. So usually it's total and direct. Sometimes they'll give you indirect, but usually they'll just give you total and direct. AST, which stands for aspartate aminotransferase. ALT, which is alanine aminotransferase. And as you pointed out, alkaline phosphatase, ALP, or sometimes you'll see AP, which are my initials. So I always remember that one.
I have a question. What about GTTP?
Those are not part of the standard LFT panel, but you are correct. GTTP, gamma glutamate aminotransferase, is sometimes, right? But that's not part of the standard panel, usually. It's usually just these 4.
Thank you.
So TI, so AST, right? Aspartate aminotransferase and alanine aminotransferase. Are these normally found inside of cells or outside of cells? Like, in other words, are you normally found in your serum or are they normally found inside of some cells?
I think they're typically confined to the liver.
Yeah, they're a little bit more broad than that. I think it's like in muscle cells in general, and ALT is found in some other things. But yeah, but generally they are only inside of cells. They should only be inside of cells. So in other words, AST, ALT, these are supposed to be liver cells, right? So they are normally found only inside of cells, not in the bloodstream. They would only be found in the bloodstream in very small amounts. So TI, so when we measure these LFTs, what are we actually measuring? Like, where are we actually measuring it?
In the serum?
Yeah, we're actually measuring it from their blood. You do venipuncture, you draw some blood, and then you're looking at it in the blood. But again, these are only supposed to be found inside of cells. So Claudia, so AST and ALT. So if these are elevated on a serum test, what does this indicate?
High cellular damage.
Exactly. So this is one of the things that really confused me when I was a medical student. It was like, oh, we're measuring these enzymes. So I was like, so there's more enzyme activity in the blood? I don't understand. It's actually much more simple than that. And as Claudia very, very clearly pointed out, there's damage. If there's damage to these cells, then the enzymes, the AST, ALT that would normally be there, are now suddenly found inside of the blood. So if you have usually liver damage, right? So if I have liver damage, then the AST and the ALT from inside of the liver cells will now spill out because I've got cell necrosis or damage, and it'll be in the blood. And so when I measure it in the blood, it won't be elevated. This is basically the same idea behind measuring just about any enzymes that we measure in the blood, like troponin, CK, right? All that stuff. Same idea. LDH. So Paula, so alkaline phosphatase, right? What organs release the majority of it? Saba?
Is it the bone and gallbladder?
Oh, pretty much. Not necessarily gallbladder. It's actually liver, which I was actually surprised with. I actually didn't realize. I had to look this up. I was like, I wanted to make sure. But it's actually liver, which is interesting. I actually didn't know that. But bone, yeah. So bone and liver. So you can also, just for your knowledge, it's also released from the placenta. So sometimes on questions, you'll have some pregnant women in the first trimester, and she'll have high alkaline phosphatase. You should still probably check a GGTP just to check, but it's probably from the placenta often. So yeah. So what role is it thought to play, Jay? Do you happen to know what role it's thought to play in bone? I don't think I knew this at your stage.
I know it's released if there's bone breakdown.
Interestingly, it's actually released when there's bone buildup. It's actually thought to have a role in normal bone mineralization. So phosphatase will cleave pyrophosphate, which is a complex thing, but pyrophosphate generally will inhibit bone. So it destroys an inhibitor of bone formation. So it's a double negative, right? So it destroys an inhibitor. It inhibits the inhibitor, so it causes bone mineralization. Thought to be. The funny thing is that no one actually knows what alkaline phosphatase is used for. I spent a lot of time looking, but everywhere I looked, they said, we don't actually know what most of these alkaline phosphatases are doing. I was like, oh. So Miriam D. So use the proposed role in bone to explain what bone conditions it's elevated in.
Anytime you have bone turnover, so I would say osteoporosis, osteomalacia.
So close. You are correct about the osteomalacia. So vitamin D deficiency, right? So kids are osteomalacia, right? It's not, you don't really see an osteoporosis so much. But anytime that you are actively making bone or you are trying to make bone. So vitamin D deficiency, sorry?
Like not in when you're losing bone density.
You would not see an increase in alkaline phosphatase if you're losing bone. But if your body is making bone or trying to make bone, so if you're making bone like Paget's, you see an increase in bone. Vitamin D deficiency, you're not necessarily seeing an increase in bone formation, but it's like your body's trying to make more bone. That's why they say they have more osteoid, right? The osteoid is basically just like the collagen. So you are trying to lay down all that collagen and you're trying to mineralize it. You just don't have the calcium and phosphate to actually mineralize it, but you're trying to, right? Which is why your alkaline phosphatase is increased. Cool? Yep. Yeah. Again, interestingly, we don't really know what alkaline phosphatases are supposed to do in most cases. We've got an idea in bone, but that's about it. For the liver, I don't know. It's funny. We don't actually know what the kidneys are filtering out that's so bad. We know that it correlates with having high creatinine and urea, but it's not your creatinine and urea that are bad. So interesting how much and how little we know about medicine all at the same time. So Rosa, so alkaline phosphatase. So elevated levels indicate what in the liver? Why is this thought to occur?
In the liver, would it be production? No, I really don't know.
Yeah. So, sorry, Saba asked the question. She said, would you also see elevated alkaline phosphatase in prostate cancer meds? I think so, yeah, because prostate cancer, I believe, is osteoblastic. So if you're making more bone, then yes. But to return to Rosa's point, so elevated, so interestingly enough, so biliary obstruction, the thing that you must know, the thing that you have to understand is that biliary obstruction leads to an increase in alkaline phosphatase. So I thought for the longest time that this was because alkaline phosphatase spills into the blood, that you block the biliary tract. And so just like bilirubin, right, you conjugated bilirubin that basically spills into the bloodstream. I thought that the same thing was happening with alkaline phosphatase, that somehow there was alkaline phosphatase within the lumen of the biliary tract and that it would leak into the bloodstream. It turns out that's actually not true. That's actually not the reason. The reason is because you increase synthesis of it anytime you have biliary obstruction for reasons that are beyond me. I do not know why. But yeah, it's actually because of increase in synthesis. Because I think that's important. It's an important distinction to make because, again, you would think if it was something that was, again, it's found in liver cells. So you would think that any time that you had damage to liver, you would also see an increase in alkaline phosphatase. But that's not really true to the extent that you'd think, right? You would think that AST and ALT and alkaline phosphatase should all increase by the same degree if you had liver damage, like hepatitis. But that's not actually true. AST and ALT go up much more than alkaline phosphatase does.
Alec, one question. So then the normal levels for AST and ALT would indicate Just the turnover of the hepatocytes, like the
Like
normal.
damage to the cell membrane of hepatocytes, therefore allowing like usually necrosis, right? But damage in general to hepatocytes. And so release of AST and ALT into the bloodstream.
If there is something that is causing major damage, then that's when we see the levels like substantially increase.
Yes, exactly. Yeah. So like usually it'd be like really bad hepatitis or shock liver where you get like ischemia to the liver for a long time, or acetaminophen toxicity, like really bad Tylenol toxicity to the liver. Yeah. Those are the classic ones. Yeah. Yeah, but it makes sense. Whereas alkaline phosphatase, again, sorry. I'm getting ahead of myself. So Shama, so if you see an elevation in alk phos, what test should you order next and why?
You would get a GGT to check if it is from the bone or just the biliary tract, the liver actually.
Yeah, exactly. GTT. I don't know what's GTTP, transfer race. I don't know, because sometimes it's written as GTTP, but I don't know where the P comes from, in fairness. So it's more specifically, because so GTTP is found more in the biliary obstruction rather than elevation for other things. So yeah, so exactly. If you're trying to differentiate between bone or like placenta, so like in a pregnant woman, you're going to see an increase in alk phos. You should probably still check a GTTP just to see if they're having biliary obstruction or if it's just because of the placenta. Cool. All right, Leah, we are back to you. So in our Gilbert patient, explain the AST, ALT, and alk phos.
In alcoholics or patients that drink a lot, why is the GGT elevated in isolate for?
I don't know. I looked for that. I don't know. It's a great question. It is true. GGTP is elevated in alcoholic patients, but I don't know why. If you find it though, I have faith, Matan, that you'll find it. If you find it, you tell me. All right, Leah. So in our Gilbert patient, explain the AST, the ALT, and the alk phos.
So the alk phos 40, I think, is within the normal range. And I think for the AST and ALT 20 and 21, those are both within the normal ranges as well. So the Gilbert patient he's born with the condition, and you're not having any sort of injury to the hepatocytes like we were talking about. So your AST and ALT wouldn't be expected to rise. And the alk phos also, the liver isn't, so when you're not having any bone issues and your liver is not being injured, I guess I would say. So same thing.
Again, this is why I know it sounds silly that like you should learn why alk phos is elevated, but remember, even though it's in hepatocytes, the reason why it's elevated is not because of liver damage. Usually when it's elevated a lot, like when it's disproportionately elevated, it's not because of liver damage. Why is it? Under what circumstances is alk phos disproportionately? Biliary obstruction. So you wouldn't expect, that's not a biliary obstruction problem, so your alk phos isn't elevated. So I loved your reasoning, right? You were like, it's a problem with conjugation. So you wouldn't expect the AST and the ALT to be elevated. That's great. But also remember that the alk phos wouldn't be elevated. You could use similar reasoning, but really the reasoning that I think would be more precise is to say you don't have biliary obstruction, therefore biliary obstruction or bone formation or the placenta. So you don't have alk phos elevated. That was good. Yeah.
I have a random question too, just about the alk phos. You said, I know the placenta thing, I've seen that before in questions, is if you have a teenager or something, I've never seen that in a question, but if they're like growing a lot, does that?
Oh, great question. Yeah, actually, in my reading of this, apparently children can have elevated alk phos. Yeah, like kids. I don't know about maybe. Oh, you mean someone going through a growth spurt? Presumably, yeah. I don't know.
I just hadn't seen that before, but
No, it's a great point. Yeah, it's funny because I was reading. I was like, yeah, if you Google it, you're like, oh yeah, oh interesting. Like they'll list the populations in which you see it normally. But yeah, children are one of them. Matal?
Patients with fractures as well, right?
Yes, I think so. Yeah, because again, you're building bone. Yeah. Yeah, it's pretty cool. I know. Yeah, it is valuable to learn why. I know that in medical school, they don't teach us this, but it is valuable because then you can basically predict, which is great, Leah. That was fantastic. It was such a good question, right? Because that's exactly the kind of reasoning that you want to have, both on tests, but also just in life and in your clinical practice, because it would make sense. It just makes total sense. All right, so Fong. So LFTs, use what is measured to explain why the LFT, the liver function test, is actually a misnomer. Miss is wrong, or I think bad. Nomer is namer, right? Nome is name. So why is it improper to call LFTs like liver function tests?
I don't know the answer. The liver function test is to test the liver function, yes, and the AST, ALT, and they are about to.
Is that testing your liver function though? AST and ALT. Like, what about your function is that testing?
The other liver function include like a synthesis and the.
Yeah, exactly. And so AST and ALT, does that give you a measure of their synthesis? Their synthetic? No. Alk phos, does that really give you a sense of their synthetic ability? No. Bilirubin, maybe. I guess that could be be convinced that bilirubin, because making direct bilirubin, sure, is the measure of their liver's function, but it doesn't really tell you, it's not really telling you about their liver function. So I'm not the first person to point this out, but calling them liver function is wrong, right? Because they're not really a measure of liver function. Certainly not of the liver function that we care about, which is that we follow most carefully, which is their synthetic function. So Satya, so what is measured instead? If we wanted to measure someone's synthetic liver function, how would we actually do it?
Synthetic liver function. That means not the excretion part.
Exactly. Synthetic meaning making stuff. So
Just
how would we
making
measure our proteins, our liver's ability
to make protein. For example, I don't know if ALT should count.
because again, it's elevated. So yeah, no, that would be a not a great measure of liver function. Sure, you make it in the liver, but if it's in a hepatitis C patient who is like a failing liver, you couldn't really follow their ALT.
I was going to ask if PT or INR could be followed.
Yeah, perfect. That is one of them. PT and INR is one of them. Great. And then Rosa, what's the other one?
I said albumin.
Yep, you got it. Yes, exactly. So it's those two are the major ones. So albumin is one, and then PT is the other. And so let us go to IO. So albumin is made in the liver, right? And so most coagulation factors are also made in the liver. So again, if you have low synthetic function, you're going to have your coagulation factors are going to go down, and so your PT is going to be elevated. So if you actually want to look at, so these are the ones that we actually use. So if you want to test someone's synthetic function, the classic ones to measure are PT and serum albumin. And gosh, we run IO. In liver failure, what's affected first? The serum albumin levels or the PT?
I want to say the albumin.
Try again.
PT?
PT is affected first. Do you happen to know why?
Because if there's a decrease in the function, then there won't be production of the proteins, which is one of the proteins that it produces is the protein. So
True. Although, so the answer actually has to do with half-life. So what has a longer half-life, do you think? All of the coagulation factors or albumin?
albumin, I want to say albumin has a longer half-life, but yeah.
So if I were to stop making all proteins, what levels are going to decrease first? The
Coagulation factors will decrease first.
Exactly. Yeah. So PT is affected first. That is because factor 7 in particular has a very short half-life, somewhere in the order of 3 to 6 hours. So in other words, if I stopped making proteins, my factor 7 levels within 5 hours would be half. And then within 10 hours, 6 to 12 hours, they would be like a quarter. So that's very quick. So within a day, I would have basically very little factor 7. It takes about 5 half-lives to get to 5 half-lives to basically reach steady state or to have something clear from your body, be completely cleared.
Very quickly, is this why we would use PT instead of PTT?
Yeah. Yes, because PT is affected first. I presume your PTT would also be affected, but yeah, the reason why I use PT is because factor 7 has the shortest half-life of all of them, or at least my understanding. As opposed to albumin, as IO pointed out, albumin has a very long half-life. So again, 5 half-lives to go from 100% to 0, or to go from 0 to 100%. That's like semi-common pharm question for step 1. So it would only take about 15 hours to get to near 0 levels for factor 12, like less than a day. But for albumin, 5 half-lives is like 100 days. That's almost 3.5 months. So if the liver stopped making albumin, the levels wouldn't fall for a while. Cool? All right. So Matan, so acute versus chronic liver failure. So what lab values would you measure to differentiate between the two? And how would you use the results to differentiate between them?
So you do your AST and ALT. The ratio of the two helps you differentiate between acute and chronic, and specifically some of the causes of acute. I just can't remember the ratios offhand.
I think you're thinking like alcoholic versus viral hepatitis.
I am, and I know chronic fits in somewhere between the ratio of 1 and 2.
So maybe I don't think I'm asking the question very well. If you were actually to differentiate between like synthetic failure, because again, remember liver failure and because the LFTs, although they are called liver function tests, aren't really telling you about the liver function. They're really just telling you about liver damage or bilirubin / bilirubin production and conjugation. So like not really telling you about function. So liver failure isn't defined by a certain AST or ALT value. Liver failure is actually defined partially by synthetic function.
Yeah. So then I would use the clotting factors for PT, INR, and albumin levels.
Great. And so how would you differentiate? So what would if it was acute liver failure, what would be abnormal versus chronic? What would be abnormal?
Given the half-lives, you'd probably have a normal albumin level and elevated PT-INR level.
In
And
which,
chronic both be deranged.
perfect. Yeah, exactly. And that's exactly what you're supposed to do. Yeah. So you'd measure the serum albumin in PT. In acute liver failure, your serum albumin would be normal because it's got a really long, like weeks. Versus PT would be up because again, if your liver stopped making coagulation factors, right, your factor 7 levels would fall basically in a day within like 12 hours. Versus chronic liver failure, that would be enough time. So if it was now weeks to months, your serum albumin would be much lower, as well as your PT would still be high. Your PT would be high in both cases, but your albumin would be normal in acute liver failure because it hasn't had time to fall. Versus in chronic liver failure, it would be low. Cool. Perfect. These are the things that I wish that I had known. And again, they're not that hard. They're really they're really not that. So we are back at our vignette. So what I want you guys to do is, again, revise your pathophysiological chronology in the next couple minutes, and we will talk about it again and wrap up. Cool. So I want to do something a little different for this one. So instead of telling you my pathophysiological chronology, I'm basically going to read this question as if I was reading it for like real. So just to give you a sense of what the sentence by sentence analysis would look like for this question. So we've got a 15-year-old boy comes to his physician for nausea and vomiting for the past 2 days after school potluck. So we can assume that he probably got sick from the potluck, but that would be my guess. So pretty nonspecific, probably several of his classmates and teachers reported similar symptoms. So definitely something. So definitely some sort of foodborne illness from the potluck. It's usually the potato salad, whatever has got like dairy. Temperature is normal. Blood pressure is normal and pulse is normal. So in other words, he's had nausea and vomiting, but it's not so bad that he's like, that his heart rate, because again, his heart rate would be high first. So the real big one is that his heart rate is normal. On exam, there's mild sclerolectrus. So now you're thinking like, so he's got nausea, vomiting. So you would be thinking, this is at the time, because up until this point, obviously you have no clue that this would be like Gilbert, but this would be the first clue. Sclerolectrus, so he's got jaundice. So you're thinking, honestly, you might be thinking hepatitis. So I probably would have been thinking hepatitis. It's like hepatitis, maybe. And so abdomen is soft, non-tender, and mildly distended. So pretty non-specific. Soft, non-tender tells you it's not. We weren't really thinking hid peritoneal signs. And mildly distended, probably just because of his nausea. I don't know. That's not specific. So the labs are really the key here. So in this case, he's got high bilirubin, but his direct is low. And his alk phos, his AST, and his ALT are all normal. So that tells you that this can't be hepatitis. So we'll learn about how to recognize the different patterns of basically bilirubin or LFT abnormalities in general, but this would be an isolated hyperbilirubinemia. So specifically an isolated unconjugated hyperbilirubinemia. So there's really not that many things like that. The big ones would be hemolysis, or would probably be the most common. So in this case, it would be Gilbert. And yeah, so I guess in fairness, I probably should have included his hemoglobin in this in retrospect, because in fairness, this could be hemolysis. And yeah, it'd be hard to tie that in with the potluck, but you couldn't eliminate hemolysis by these labs, because hemolysis would also look like this in terms of the labs. So cool. And so my pathophysiological chronology we already talked about. This is what it would be. And so any questions about that, about my analysis of that? Or you're like, nah, like that was not very good. This is how I would have analyzed it.
Dr. Palmerton, I'm a little confused about how several of his classmates and teachers reported similar symptoms.
Just saying bad thing.
But then are we to assume that they all have Gilbert syndrome?
Oh, sorry. Oh, I see. Oh, great question. By similar symptoms, I meant that they all were nauseous and vomited, not that they all had jaundice. That is a fair question. The sequence, though, is, yeah, similar symptoms, because we didn't hear about the jaundice until the fourth sentence question.
Yeah, and what you said made sense, like syntactically.
But it's a very good question. Yeah, I should have made that more clear. Reported similar. Yeah, that's a good question. Yeah, this is why I like to do this, because yeah, I can see. Oh yeah, probably would have added the hemoglobin. Probably should have.
Yeah, on that, I have a question. Like, what if you have some type of like DIC or some type of some bacteria creating exotoxin that would cause a type of intravascular hemolysis? Would this be?
But he'd be a lot sicker. DIC, to be that sick, you'd be a lot sicker. Like autoimmune hemolytic anemia would be the other one. It's a little bit less likely, but that would be the other one that I think would be possible. Would be autoimmune hemolytic. So in other words, to get that question correct, you would have had to have looked at the answer choices and determined hemolytic anemia. Doesn't make sense.
Why would he have been asymptomatic until the potluck?
because he'd never had that kind of stressor before. Because there has to be some kind of stressor. So that's why it's like classically like a college student that's like pulling all-nighters, because you've never put that much stress on your body. Right?
Okay.
There's like
And
different
so
types of
and so we assume that the liver experiences that stress, and then in response, it just really just stops. Like the UDP glucuronoltransferase just stop.
Great question.
Thank you.
Other questions?
May I ask one question?
Of course.
How is this different from hemolytic uremic syndrome?
HUS? Oh, could this be HUS? Yeah, I guess, because the problem is that nausea, vomiting are very non-specific, right? So someone eats something, they get nausea and vomiting, and then yeah. So I guess in theory it could, but they would be a lot more sick. HUS is, they could, like, the whole point of these labs is that it's like his vitals are normal. He's only got very mild icterus. He's otherwise just pretty well. He's just got little yellow eyes. That's classically how Gilbert is going to present. They shouldn't have really many other symptoms. But yeah, like HUS, you'd be a lot more sick. And yeah, because again, like HUS, classically, you'll get like neurologic problems, and you get kidney problems, and you'll get hemolytic anemia and thrombocytopenia and a number of things. That's the classic pentad. Oh, this is fun. Oh, I like this. I don't know how you guys felt. I've been thinking about doing this, of just, instead of just rereading the question, just read it as if I was like taking the test. But this is, I think, could be.
Yeah, that was really helpful to hear your thoughts as you were reading each, I guess, symptom.
Cool. Yeah, I think I'll do that because it doesn't take that much more time. So Risa says yes, very useful, as does Sujith. Great, awesome. We are back to our summary of key concepts. Again, I won't reread it, but it's fun, right? It's fun to think that something so simple like a porphyrin ring in heme can be tied to jaundice and bilirubin, right? There can be tied to the color of your urine if you have cholestasis, if you have biliary bile stuff. Right. It can be tied to the color of urine, just period, because it's a urobilin. It can be tied to the color of your poop being brown, or the color of your poop being clay colored if you have no bilirubin getting into your stool. You can tie it to the color of your sputum. Your sputum, if you've got bacterial pneumonia versus if it's clear, if you've got viral pneumonia or just pus in general, right? The green color of all the wonderful green things in spring and summer. It's pretty cool. It's all very similar. Gilbert we talked about basically is a way of talking about all these things. And then we talked a lot about LFTs, right? Alk Phos, and how you can use the fact that it's increased in bone production to explain varied things like why would you see it in like children that are undergoing a lot of bone growth or in fractures or in biliary obstruction or all these things. You can explain it. Why is AST and ALT higher in really bad liver damage? All these things. It all has a logical basis. So thank you so much for this. And yeah, I'm looking forward to next time. We're going to talk next time. About more about this. And yeah, we'll talk about, it's actually about Kuhn's. So
Alec, before you go,
yeah, please.
There's another disease. I think it's Crigler-Najjar or one of those.
Yeah, so Crigler, I don't know how to pronounce it. So Crigler-Najjar is where it's basically a really extreme form of where you basically have no or extremely low UDP glucuronoltransferase function. So they present basically at birth, and it may not even be compatible with life depending on how severe it is.
Cool.
Yeah. Satya asks, can we do more PCs? That's super helpful. What do you mean by PCs?
The pathophysiological chronology. It's just helpful to think how you're thinking.
Oh, yeah. Oh, every
Yeah.
single time we do, this is what we end with, is the pathophysiological chronology. So
Cool. Thank you.
glad. Yeah, absolutely. All right, guys. Any other questions, thoughts, concerns?
I have one more question. How do we get from, I guess, the GI bug, the gastric stress, to the low activity of UDP? We already know he has low activity of the UDP glucuronoltransferase. Is it an elevation in bilirubin that causes that decreased conjugation to be a problem? What is in between gastric stress?
No,
and
it's
low
actually the stress itself causes the UDP glucuronoltransferase activity to go down.
So your baseline bilirubin is
So
But-
like
but you're-
normally like you have enough. So in other words, you have enough UDP glucuronoltransferase activity without stress that you can conjugate all the bilirubin that you produce, or a normal amount of bilirubin. It's
Okay.
just that in Gilbert, because I think under normal circumstances, UDP glucuronoltransferase activity decreases. And so the Gilbert, they have like slightly decreased levels. You can think of it as they have slightly decreased levels at birth. So normally that doesn't cause a problem. However, when you get stressed and your UDP glucuronoltransferase activity decreases even more, Now it suddenly becomes a problem. Now you do not have enough activity.
How does that explain the total increase in bilirubin?
Because you can't conjugate it. So because you can't conjugate it, you can't eliminate it.
Sorry, yeah, that makes sense.
Cool?
Got it.
Oh,
Yeah.
great question. Fantastic question. Yeah. Yeah, I don't think I did not make that clear. So yeah, cool.
I have a question to follow just that up. You said you can excrete the bin that's just formed. Wouldn't that go as bilirubin and just be out? Because I would think either it's conjugated or it's unconjugated. So if I'm not able to conjugate it, then the unconjugated bilirubin should just be absorbed through my intestine.
Yeah, exactly.
So then I will.
Your bloodstream. Or
it
it
goes-
wouldn't even
oh.
make it into your GI tract in the first place, presumably.
Oh,
Right.
yes.
If it's not conjugated, remember, like in general,
Yeah.
things that are non-polar are absorbed pretty well. Things that are not, the things that are polar are not. So morphine is very polar. It's like you have to take many times the amount of morphine orally as you would get, because oral morphine is not absorbed well because it's very polar. Fentanyl
Right.
is very non-polar. Fentanyl, IV and oral are like very similar in terms of their overall effect. That's why they make like fentanyl patches. That's why they make fentanyl lollipops, because you can absorb it really well. Non-polar. All right, guys. Well, thank you very much. Take care. So today I want to switch gears and talk about endocrinology. Okay. So specifically diabetes mellitus and thyroid hormones. These are probably two of the most important conditions that are in endocrinology, and I think that they can tell us a lot about other diseases as well, which is why I wanted to start with these. We'll talk a little bit about diabetes because we've covered it in other sections, particularly in the biochemistry section, but we'll spend the majority of today talking about thyroid hormones. So let us get started. So remember, these are the pathogenesis to presentation questions. These are the things that you are supposed to understand. And if you understand them, you'll understand the vast majority of what it is that I talk about in this lecture. So at the end of every lecture, at the bottom, I post these along with the answers so that literally all you have to do is watch the video and then copy and paste the answers into your cards. And as long as you've done the work of doing your cards every day, you will never forget the information in these cards. And if you read the article that I released last Sunday, you'll know that the NBME cares most about your ability to apply information. This is applied information. And so if you understand this, it means that you are able to apply it in some way that's clinically relevant, which is exactly what they're asking you to do on all of your NBMEs, all of your USMLE step 1, step 2, step 3, and shelf exams. So after this is your goal. You want to understand all of these. Okay, so let's get started. So let's start with Alex. So Alex, what exactly defines diabetes mellitus?
I guess insulin dependence or maybe for glucose control.
Yeah, it's the second. So it's interesting because it's like we think of the mechanism, but really it's just high glucose, high blood sugar, right? That's it. It's defined operationally is how it's described. So there's different cutoffs, right? So fasting glucose above 126, 2 times, or non-fasting above 200, 2 times, or A1C above, I think 6.5. Okay, so for diabetes type 1, Catherine, what is the general pathophysiology, just generally speaking?
Okay, so I guess a decrease in insulin causing an increase in glucose.
Perfect. Yeah, exactly. So it's usually autoimmune destruction of the pancreas, which leads to a relative insulin deficiency, which leads to too much blood sugar. Great. So Danielle, what would be the general, this is a harder question, so what's the general pathophysiology of diabetes type 2?
So for type 2, you have insulin resistance. So your body, the cells can't utilize insulin and uptake glucose. So then your body thinks that it's not producing insulin because your body is not registering it. So it overproduces insulin. And then that causes I'm trying to think of the word, destruction of cells. What's that protein?
Amyloid.
Yes, amyloid. Sorry,
Yeah,
having a brain
exactly.
fire. Yeah, production of amyloid, and that's destructive to cells.
Yeah, that's actually pretty good. I don't know that I would say that this body doesn't recognize that it's producing insulin. I guess probably the more accurate way of saying it is that because of the insulin resistance, we'll go through it. So because of the insulin resistance, you have to overproduce insulin in order to bring the blood glucose down, right? And so amylin, one of the byproducts of too much amylin production is amyloid, which gives you beta cell dysfunction, which gives you a relative insulin deficiency and hyperglycemia. So again, they both are ending in
blood sugar that's too high. We'll talk a little bit more about what amyloid means, because this is something that was really confusing to me for a while. So we have some diagrams that we can explain. So Elaine, can you tell me, would you produce more or less insulin in early diabetes type 2 than a normal person?
So you would produce more insulin than a normal person?
Yeah, why?
Because like in the previous explanation, it says that in type 2 diabetes, you have an insulin resistance. So your body tries to compensate by overproducing that insulin.
Yeah, exactly. So it's interesting, right? Because like you wouldn't necessarily think of, like I never really thought of diabetes type 2 as being like, oh, I'm actually making more insulin than normal, but that's actually what you see. And even like pre-diabetics, right? When they say like you're pre-diabetic, that's really probably where the insulin production is highest. And so the point is that over time, eventually, because of that amyloid production, you get beta cell dysfunction, and that causes you to not be able to produce enough insulin. Perfect. So Elisa, what exactly is amyloid?
So to my understanding, it's basically misfolded protein, and you can have that from all kinds of diseases where protein ends up precipitating in different organs. And usually proteins are being degraded by the proteasome, but in case of amyloid, that protein isn't degraded correctly and ends up participating.
Good. That's actually surprisingly good. Can you tell me why, Elisa? Like why exactly does that happen? That you get this accumulation of misfolded proteins?
It has to do something with a general overproduction of that protein, that I guess I could imagine that reading everything at a time isn't sufficient enough.
Yeah. So the way that I understand this, the way that like my reading of this is that during protein synthesis, right, there's always some fraction of proteins that are misfolded. That's just a natural thing. Our body takes advantage of this by using MHC1, right? So the proteins that come from the proteasome are loaded into MHC1, if you'll recall from immunology. And because it's sampling, because some fraction of all the proteins that you make are going to be misfolded and need to be ubiquitinated and broken down, right? So those fragments are loaded to MHC1, and that it's loaded into the outside of the cell, and so that gives CD8 cells a sense of what's going on inside the cell. So we take advantage of this, but some fraction of proteins always misfold. So they're ubiquitinated, and then they go to proteolysis, the proteasome. You need to remember the ubiquitination proteasome. For some reason, they just love that for step 1. They just love it. Ubiquitin proteolysis, like is a disproportionate number of questions about the proteasome. You just have to remember that that's all. That's like oftentimes what they're asking you. So what you also need to know is that there's some parts of proteins, right? So proteins are often made up of what are called peptides, right? So peptides are just sequences of amino acids. And so oftentimes you'll put together these peptides into proteins. And so some part of them can't be broken down sometimes. So the hydrophobic part is a part that oftentimes can be broken down. And so those things will aggregate. They will form, they will clump. And it kind of makes sense, right? Because if something isn't soluble, if something isn't dissolved in the blood or in the cell, it would make sense that a protein wouldn't be able to necessarily degrade it, right? Something like that's solid, that's inside of the cell. So in simple terms, if I were to explain this, I would say that a misfolded protein needs to be broken down, right? So it's ubiquitinated, needs to be broken down. However, not all the parts of the proteins can be broken down. Those parts that can't be broken down will accumulate and they'll bind to each other to form amyloid. Does that make sense? So the question is why is it so bad? So Jason, why is amyloid so bad?
I would say because it can be deposited in like tissues and cells where it can obstruct natural physiological processes.
Perfect. Yeah, that's like a great med student answer. Big words like physiologic process. That's good. Yeah. Yeah. It just causes cells to dysfunction. Perfect. So makes sense, right? Because it's hydrophobic, so it would precipitate. And so really, let's walk through the mechanism of how amyloid would form. So we've got a protein, right? Proteins are composed of different components. Usually, oftentimes, they're composed of different polypeptides, although sometimes a protein could be just a single polypeptide. But let's say that there's a protein and there's a part that you can degrade in the proteasome and there's a part that you can't. So some fraction of proteins undergo misfolding, happens to even the best of them. And so they get ubiquitinated. When they're ubiquitinated, that sends them to the proteasome for proteolysis. And in proteolysis, you can degrade the part that's degradable. However, there's some part of some proteins that can't be degraded. Not all proteins, but some proteins. And so what happens is that, because the question really is like, why do you see amyloid in protein overproduction? Calcitonin in medullary carcinoma, you have the AA amyloidosis that you get in chronic inflammation, right? Like, why? The reason is the way that I understand it is that this happens for those proteins, at least to some degree, but when you overproduce the protein, you just have a lot more of it. Right? So if you have more protein synthesis, when I have more proteins, a certain fraction of them are going to misfold. They're going to undergo ubiquitination. Those are going to undergo proteolysis. And then those are you're going to degrade the degradable parts, the proteolyzable parts. So what happens is that when I overproduce protein, so in the case of diabetes type 2, right, if I'm making a ton of insulin, which also is going to be released with amylin, some of the amylin is going to misfold. Some of the amylin is going to have to be ubiquitinated. Some of the amylin is going to undergo proteolysis, but I am going to be left with the non-degradable parts of that amylin over time. And so the more amylin, which is released with insulin, right? So the more insulin and amylin I produce, I'm actually just speeding up the degradation, or I'm speeding up the loss of my pancreatic islet cell, right? Because one of the questions is like, why, when the type 2 diabetes, why was I able to make a lot of insulin in the beginning, but why did that ability decrease over time, right? And this explains why in a very, very simple mechanism. Question so far, this is something that like I didn't understand until, honestly, probably residency or after. It wasn't I didn't understand the general mechanism of amyloidosis for a long time. So I'm sure that I didn't explain this perfectly. Questions, concerns? All right, well, let's see how I explain this. So Maliha, so absent any contraindications, what's the typical first line drug for diabetes type 2?
Metformin?
Yeah, perfect. Yeah, metformin. Great. So Manny, given the pathophysiology of type 2 diabetes, what's the mechanism of action of metformin, and why would that sort of make sense, Manny?
So I guess what I know is that it's the only drug that I remember that reverses, or I guess works on the actual mechanism of type 2 or pathophys of type 2 diabetes, which is insulin resistance. So it decreases insulin resistance, and I think it has something to do with gluconeogenesis. Maybe.
Yeah.
Does it increase glucose?
Well, if I was trying to think, okay, so you can think this through, right?
Mm-hmm.
So if I was trying to control, so diabetes is high blood sugar, diabetes mellitus by definition. So
You don't want to make more glucose.
yeah. So what effect would it have on gluconeogenesis?
Probably would decrease the liver making more glucose.
Exactly, perfect. And that was a Nature paper in like 2014. It's a big deal. They figured out that one of the mechanisms was decreased liver gluconeogenesis. Because it's still not entirely worked out. There's like a ton of different mechanisms, but that are posited. Maybe it acts in the GI tract, but they know that at least part of it, it seems to work in the liver. It's pretty cool. Yeah, so you decrease glucose production, and so you would need less insulin. So that actually works really well. So Marco, would metformin increase the rate of decay of the pancreatic islet cells? Why or why not?
Oh, it will not, because it controls the gluconeogenesis of the liver. So metformin is considered a fantastic drug for the diabetes type 2.
Yeah, it really is. It really is. Theoretically, you would even think that it might slow the progression, right?
Yeah.
If there was less insulin that were needed. If at least part of the mechanism of progression of type 2 diabetes is that you have islet cell dysfunction because you're overproducing insulin and amylin and producing amyloid as a byproduct, then yeah, I actually think it would be better. Great. Mashoud. So after metformin, what's the typical second line drug?
It'll be sulfonylureas.
Yeah. Sulfonylureas. Perfect. So Natalie, using the pathophysiology of diabetes type 2, can you explain the mechanism of action and how this would fit in?
So sulfonylureas, I believe they inhibit the potassium channel, allowing for more calcium to come in and then insulin to go out. Is that the right way?
Boom. Yeah. Well, so walk me through. So how would that work? So if I close potassium channels, what effect is that going to have on cell membrane depolarization?
Well, it's going to cause the cell membrane to remain at a negative action potential, because then the calcium will come in because it'll want to go towards the negative.
Not quite. So calcium wanting to come in is irrelevant in the sense of like whether it comes in or not, right? Calcium will come in if the calcium channels are open.
Okay.
Right. In other words, if I were to hyperpolarize the cell even more, in other words, if we're inside of the cell even more negative, you're not really going to have that much more calcium come in. That's not the mechanism that drives calcium in. The mechanism that drives calcium in is just depolarization of the membrane.
Okay, and then that causes the insulin release.
Well, that causes calcium to come in.
Okay.
Right. So
And that calcium allows for the binding of the insulin vesicles. Correct?
exactly. Yeah. So snare and snap proteins, right? The things that are cleaved by, well, you tell me actually. So what do you know what cleaves snare proteins? That's a microbiologic protein.
Can't think of it.
Botulism.
Oh, yes.
Botulinum toxin, right? So it prevents, right? So acetylcholine, right, which activates nicotinic receptors at neuromuscular junction, is in vesicles, and the vesicles need calcium to activate the snare and the snap proteins. So they will botulinum toxin cleaves those. I think it's snap, one of the snap proteins, but something in that complex, and it prevents the release of acetylcholine, right? But it's a calcium dependent mechanism. So the calcium influx causes the release. So yeah, so you close the ATP gated potassium channels, and that causes depolarization of the cells. That causes, I didn't say it here, but that causes calcium influx, and ultimately that causes insulin release. I don't want to get too far into that mechanism. If you guys don't remember it, that is covered in the biochemistry lecture. So look for the lecture on glutamate dehydrogenase deficiency. Glutamate dehydrogenase, I think it's a hyperactive radiation. But yeah. Okay, so Paula, can you tell me, would sulfonylureas increase the rate of decay of the pancreatic islet cells? Why or why not?
I think they would, because they push you to release more insulin, and I think that will probably increase the insulin production.
Yeah, exactly. Right?
Increase the amyloid.
Yeah. So unlike metformin, which decreases my glucose production, right? Sulfonylureas go on the opposite end. They're just trying to increase my insulin production. The problem is that, again, part of the problem with type 2 diabetes is that we are overproducing insulin, which is causing overproduction of amylin, which is causing amyloid production, which is causing the beta cell destruction in the first place. So by the time that you're on sulfonylureas, you're already essentially you're kind of like flogging a dying pancreas. Right? It's like, I imagine like an old horse and carriage setup, and you're just like, the horse is like dying, but you're like just beating it to try to get it to go faster. And it doesn't end well, as we will see.
Sounds disturbing.
I know. So imagine that next time you see sulfonylureas. So Perlina, so after sulfonylureas, what typically is the next step in pharmacologic management?
So after sulfonylureas, at that point, the pancreas is dying, so you go to insulin.
Yeah, usually you go to insulin. Again, like there's all these like second and third line things, and maybe there's something else, but in general, this is the typical steps. So you start to give them exogenous insulin. So Sebastian, if you are using the pathophysiology of diabetes type 2, what's the significance of getting to the point of using exogenous insulin for glucose control?
Well, basically you start with the sulfonylurea, right, to make more insulin as well as aniline. So you destroy your pancreas, basically, specifically beta cells. So you need insulin, exogenous insulin, because you can't make insulin yourself. So
perfect. Yeah, exactly. So if we think of, right, this is a long explanation, but if you think of like sulfonylureas as sort of like flogging a dying horse, the horse is like kind of dead by the time that you're using insulin. Like it's not fully dead, but it's like getting there. And so you now need to bring in outside insulin to help it along, right? Because there's no way that you are able to produce enough insulin from your islet cells. So perfect, nice. It also explains, I mean, so like you can also use this to understand why, for example, I didn't talk about this in this lecture, but why, for example, metformin doesn't cause weight loss, but the other drugs do, right? Because again, insulin is like the whole basis of keto diet and Atkins and low carb is basically because insulin causes you to prevent lipolysis, right? Because insulin blocks hormone-sensitive lipase, right, which is what breaks down fat in your adipose tissues. And insulin increases the activity of acetyl-CoA carboxylase, which is the key regulated step of making fatty acids. So in other words, insulin causes you to not break down fat and to make fat, right? So metformin, guess what? Doesn't cause you to increase insulin. If anything, it probably decreases your insulin. And so it doesn't cause any weight gain. Guess what does cause weight gain? Phosphorylureas, right? So you can use the mechanism, right? So again, they'll test you on related things. They might not test you on exactly this thing that you've learned, But if you understand the mechanisms, you will be able to use that knowledge in a question that's related as well. All right. So questions before we move on, because we are going to move on to the HP and organ axis next. Things that I didn't explain well. All right. Okay. So next we're going to talk about the HP and organ axis, right? So it could be the HP thyroid axis, HP A axis. So the general way that you have hormonal control in your body is that you have the hypothalamus, which releases some releasing hormone, right? So TRH, right? Thyroid releasing hormone, let's say, for example. It acts on the pituitary, the anti-pituitary should be, and that releases a stimulating hormone like TSH, which works on some sort of end organ, right? Like the thyroid or the adrenal cortex or something. And then you release some sort of hormone, which then inhibits the upstream things, right? Like it'll inhibit the pituitary and the hypothalamus, for example. Okay, so that's the very like 20,000-foot view of how the endocrine systems, basically most of the endocrine systems work. Okay, so let's start with some terminology. Alex, can you tell me what exactly does it mean to have a primary endocrine disorder?
So like primary and secondary is talking about like where the disorder is.
Perfect.
So primary is, sorry, I'm blanking. I think primary is the organ itself.
Perfect. Yeah, exactly. And secondary would be where?
Secondary would be like anything downstream of the organ.
Downstream be actually upstream. So primary means it's a disorder of the end organ itself, right? So if I said someone has primary hypothyroidism, Catherine, what would that mean?
Okay, so hold on, let me think this out. So if somebody has primary hypothyroidism, okay, so I think like autoimmune or Hashimoto, I think a decrease in T3, T4. So it would mean like, so low thyroid hormone levels and an increase in TSH. So
well, let's take a step back. So big picture, what exactly, I'm saying like, so primary, we said a primary endocrine disorder is a problem in the end organ itself, right?
Okay.
So the end organ in hypothyroidism is the thyroid gland.
I'm sorry, are you asking me a different question? Okay, so the end organ is the thyroid, right?
Yeah, exactly. So if it's primary hypothyroidism, like where is the problem? Is it in the thyroid?
So you'd have
Uh-huh.
right, it'd be in the thyroid, so you'd have a decrease in thyroid hormone.
Perfect. Yeah, exactly. But in other words, it's not a problem in the pituitary and it's not a problem in the hypothalamus.
Oh, okay.
Right.
Okay, I understand. Yes.
So this is an important distinction, particularly for step one, because they will ask you these sorts of definition questions. Again, they won't ask you like, what is the definition of primary hypothyroidism, but they could ask you, and they do ask, like, what would you expect to see in terms of TSH and TRH in primary hypothyroidism? So yeah, so problem in the thyroid hormone itself. So Danielle, what would secondary or tertiary endocrine disorders be?
So secondary would be like what's occurring at a different source, but affecting the organ itself, like affecting
Which source?
Be like an ectopic source.
So now you're using like general language, right? Secondary meaning like some other place. That's not what, so endocrinology is very specific terminology here. And it's important to know. So secondary refers to what?
Like I'm thinking of like, I guess for like an example, like
It's the pituitary.
okay.
So in other words, the organ that is just upstream of the end organ itself.
Okay.
Right. So what would a tertiary endocrine disorder be?
Would that be like another source? Like a cancer or something like that?
So it would be one step up from the pituitary, which is what?
Like the hypothalamus?
Yeah, exactly.
Okay.
Perfect. Yeah. So again, these are very specific meanings, and like very few people actually know this. I'm actually like, it's again, because I don't think they teach you guys definitions. So secondary means is for endocrine disorders, right? This is just endocrine disorders. If I say that like someone has hypertension secondary to blah, 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 I don't mean it's in the pituitary, right? This is specific to endocrine disorders. So but if I say someone has secondary hypothyroidism, I mean that there's a problem with the pituitary. And if I say that they have tertiary hypothyroidism, I mean that they have a problem with the hypothalamus. Those are one and the same, okay? So let me make this very clear, right? So primary organ dysfunction happens at the end organ itself. Secondary organ dysfunction, right? Secondary hypothyroidism, let's say, happens in the pituitary. And tertiary happens just upstream of the pituitary in the hypothalamus, right? If you're having like a light bulb moment, you're not the only one, because I've seen a lot of people. The reason I know this is an issue is because I do NBME questions with students. And this is a question that gets, a lot of people get wrong. And it's really simple. It's like 3 points on your test. So again, primary, end organ, secondary, pituitary, tertiary, hypothalamus. Only for the HP end organ axis, right? If I say something is like secondary, hypertension secondary to something, I don't mean it's in the pituitary, right? That really is a general source. It could be from something general. But secondary is a very different meaning when it comes to endocrinology. Okay, so let's use some of this stuff. Elaine, can you tell me, using the definitions, if someone had primary versus secondary versus tertiary hypothyroidism, what would the TRH, the TSH, and the T3, T4 levels be?
So in primary hypothyroidism, you would see decreased T3 and T4 and elevated TSH.
But the TRH?
TRH would also be elevated.
Boom. Yeah, exactly. Why?
Because the dysfunction is in the thyroid and not in the pituitary or in the hypothalamus.
Yeah, that's true. But why mechanistically? There's really only one skill that you really need to understand about endocrinology, and it's this. You need to understand feedback inhibition, right? You need to understand that the hormone is going to suppress the hypothalamus and the pituitary. Okay. So if I have primary hypothyroidism, why would I have high TSH and high TRH? Using the concept of inhibition, feedback inhibition.
Because it will suppress the pituitary and the hypothalamus?
Well, okay, I'm making, the problem with hypothyroidism is I'm making too much or too little thyroid hormone?
Too little.
Too little, great. So if I have less thyroid hormone, am I going to suppress my pituitary more or less?
Oh, you'll suppress it less to increase.
Yeah, exactly. So so again, where it gets complicated, right? It's a double negative. Pressing pituitary less. In other words, I'm disinhibiting it. Another way of saying. How much TSH am I going to make?
More.
More. Boom. Exactly.
Yeah.
So let's use the same example with the hypothalamus, right? So if I have primary hypothyroidism, I'm going to make more or less T3, T4.
You're going to make less?
Less. Exactly. So if I make less T3, T4, what effect is that going to have on my hypothalamus?
You will increase the amount of TRH.
Good. Why?
Because you are T4.
Because you're what?
Because you're making less T3 and T4. So you are disinhibiting the hypothalamus?
Yeah, exactly. Because normally T3, T4 inhibits the hypothalamus. If I have less T3, T4, I will cause less inhibition of the hypothalamus, which means I will produce more of the TRH.
Okay.
Cool?
Cool.
Does that make sense?
Yeah.
Okay. I should have done a better job of explaining that. So, okay. But yeah, so I don't want you to think like, oh, just because the problem is, in the end organ, therefore like the upstream things are going to go up. No, you need to understand the mechanism. And that's what I didn't do a very good job of explaining. So thank you for pointing that out. Elisa, how about secondary? What would it be in secondary? What would the TSH, TRH, and T3, T4 levels be in secondary hypothyroidism, Elisa?
So in secondary, the TRH would be increased, while TSH and T3, T4 would be decreased.
Boom. Why?
So I'm lacking feedback of my end organ, and that's why my tertiary organ that's functioning is increasingly stimulating the secondary organ that's defect due to any reason.
Yeah. So in other words, if I have a pituitary problem and decreasing my production of TSH, right, it also means I'm going to produce less T3, T4. So if I have less T3, T4, I will disinhibit the hypothalamus and in theory the pituitary. Problem is I have a problem in the pituitary. So even if I disinhibit the pituitary, I can't increase my TSH. So TRH is up, TSH is down, T3, T4 is down. Great. Exactly. And then let's go to Jason. Finally, so tertiary hypothyroidism, what would be the lab values, Jason?
Is this me, Jason?
Yeah.
Okay. In tertiary, it would, let's go in order. We're going to have an issue with the hypothalamus.
Great.
And so, okay, this is great. So that's going to be where our issue is. And so our TRH is going to be low. Our TSH, would that be elevated? Because you wouldn't have the...
Oh, it's interesting. No, not usually. I don't think so. I see what you're saying.
It would be discrete.
Because it's sort of hard.
Yeah.
Well, my TRH, I can't stimulate my pituitary, but like I'm also going to be inhibiting it from this now. I think the TRH wins in this case. So if I don't have TRH, I'm not going to stimulate the pituitary.
All right. So that everything should be decreased.
Yeah, exactly. Everything is low. Yeah, exactly. And no matter how much I disinhibit these other things, it's not going to matter because for the pituitary, I don't know.
Okay, yeah, because I was thinking, okay, the pituitary.
Yeah, it's a
is
fair
trying to
question.
get
Yeah,
stimulated because not, but I see then how everything would be decreased then.
Yeah, but it's the TRH that matters. Good. Perfect.
Okay.
Nice. So Litzel. So how about if I had primary versus tertiary hyperthyroidism? What would that look like? Oh, geez. You can do this, man. You can, again, like all these things, as long as you understand feedback inhibition and the definition of primary, secondary, and tertiary, whatever organ dysfunction, like most questions will make sense to you in endocrinology. There's really not that much, honestly, to understand conceptually.
Can you repeat the question, please?
So explain to me what the TRH, TSH, and T3 and T4 levels would be in primary versus tertiary hyperthyroidism.
Oh, okay. So hyperthyroidism. Okay, so in primary hyperthyroidism, then you would have T3 and T4 increased, and then the TSH and the TRH would be decreased. And that's primary. And then tertiary, you would have, oh, wait, it's up there. Okay, so you would have T3 and T4 increased, and then TSH increased as well, and TRH increased too.
Boom. Yeah, exactly. Well done. Yeah. So in primary, right, I'm making a ton of hormone, a lot of T3, T4. That will cause an increase in inhibition of the hypothalamus and pituitary, so my TRH and TSH would be low. However, if it was tertiary, I would have a high TRH level, which means I'd stimulate my pituitary like crazy and make extra TSH. Extra TSH means I'm going to have extra T3, T4. So they're all high in tertiary. That's good. Well done. See, it's really like at core, it's not, as long as I explain it reasonably well, it's not that bad. So the key is did I explain it well? So questions so far, because I know that I didn't do a great job. Okay, well, you may just be being polite. Okay, so Luis, tell me, what are the two, like, this is a read my mind question, but basically what are the two major things that you need to make thyroid hormones? It's essentially two things. And that's it. It's like a number of chemical reactions, but what do you see there?
Okay, yeah, two major things that you need to make thyroid hormones is iodine and TSH.
That's okay. Yeah, it's a bad question on my part. So you need tyrosine.
Oh yeah, tyrosine,
which is the amino acid, and you need iodine, which is what you said. Yeah, I mean, yeah, you could argue, yeah, you need TSH and TRH and all that other stuff too. But I mean, like in actual ingredients that go in to make thyroid hormone, it's essentially just two things: tyrosine and iodine, and then you do a couple chemical modifications, but that's essentially it. So Maliha, so use the fact that it's made from tyrosine and tyrosine in particular, to explain where the thyroid hormone receptor is in the cell.
It's in the cytoplasm.
Oh,
or
yeah.
like intracellular.
Yeah, it's intracellular. Good. Why? Why is it intracellular?
Because tyrosine is a nonpolar amino acid.
Yeah, exactly. Tyrosine is a nonpolar amino acid. Yeah. So tyrosine is nonpolar. So if you remember, so it would make sense that the thyroid hormone would also be nonpolar, right? Because it's made essentially from tyrosine. And so polar substances don't cross cell membranes. And so anytime that you have a polar substance, it will have a cell surface receptor, right? Insulin is a peptide, relatively polar, it's found at cell surface receptor. Catecholamines, polar. I don't know if they're polar, but they're certainly, they might just be too large, but they are also on the cell surface. The only things that have intracellular receptors are nonpolar substances because they can cross cell membrane. So they enter the cell and then they go into they find the receptor inside the cell. So Manny, can you tell me what other hormone class has intracellular receptors?
I think steroid hormones.
Steroid hormones. Yeah, exactly. And why are they hydrophobic?
They're derived from hydrophobic substances, so they can cross the plasma membrane.
That is true, but which substance?
Is it cholesterol?
It is cholesterol. Yeah, exactly. So steroid hormones are made from cholesterol. And as anyone can tell you who's eaten bacon and tried to clean it up afterwards, cholesterol is nonpolar. Right? It does not dissolve in water. There was an article recently, I don't remember, it was like the New York Times or the Wall Street Journal. There was this article about bacon. Now everyone is like when they make bacon, because like bacon is like, it's like there's a resurgence of people eating bacon for, I guess, a variety of reasons. But everyone is putting even though everyone knows that they're not supposed to, they're putting the bacon grease in the sink. and it's precipitating, right? Because it's nonpolar. And so it like, coats all of the pipes. And there have been like just masses of bacon, or basically animal fat, that because it's nonpolar, it all just like aggregates together. And so in like water treatment facilities and like sewers, like they've had to dislodge just these gigantic, like people-sized fat clobs. So cholesterol is nonpolar. This is all to say cholesterol is nonpolar. And so it will also cross cell membrane. So steroid hormones also work inside the cell. They don't have surface receptor. And Emily has like, ew, that's disgusting. But I tell you the story because it will stick with you, right? Just like the sulfonylurea is flogging like your dying pancreas, you will remember that steroid hormones are made from cholesterol, and that they will, that they do not precipitate, or that they do precipitate in water, they don't dissolve in water. And so that's why A, they cross cell membranes, and B, they will clog all of your pipes. Jason says, now I know why my mom always poured the grease in the jar after cooking and not down the sink. Yeah, exactly. I know. Yeah, it's one of those things that's like, you can always say like, oh, it's like, okay, just like this one time, but it is bad. Because even if it doesn't clog up your pipes, like the downstream effects for the system is pretty bad. All right, so Marco. So what exactly is thyroglobulin? Like, when we say thyroglobulin, like what exactly is it? Generally speaking, what is it?
Okay, so thyroglobulin, it's a protein that's produced by the follicular cells and used within the thyroid gland.
Good. Why? Like, how is it used? And what's like the major defining feature of thyroglobulin?
What's the major what? Sorry?
Like defining feature. This is a bad question on my part.
It's a long protein. Is that it?
Yeah, it's a long protein, and it has a lot of what amino acid?
Oh, a lot of tyrosine.
Oh, exactly. Yeah. It's a really long protein, and it has a ton of tyrosine molecules.
Yes.
Right? 134 to be exact. Crazy. Right? It's just really long and has a bunch of tyrosine. Why? Because guess what thyroid hormone is made out of? Tyrosine, right?
Mm-hmm.
So why is it important to have a lot of tyrosines? We just said, right? Thyroid hormone is synthesized from tyrosine. So Mashoud, like when we say like T1 or T2 or T3, T4, what is the 1, 2, 3, and the 4 refer to?
That just means how many they're attached. I think it's how many atoms will be attached to that one
What
tyrosine.
atom? What specific atom?
Is that what type of atoms? Will be the non-polar atoms?
So remember, thyroid hormone is made out of two things, right? Tyrosine, which
Yeah,
is
so
coming-
tyrosine and iodine.
Perfect. Yeah.
Oh, iodine.
Yeah, exactly. So it refers to how many iodine or iodide atoms there are. Yeah, that's it. That's literally all it is. Right. So how would then, Natalie, how would you make the T3 precursor within the thyroid gland?
So I believe, are you talking about?
Generally speaking, again, now I'm reading these questions. I realize these are kind of vague, so I apologize.
So I mean, when the molecules come into the thyroid gland, the tyrosine and the iodine get coupled together. And so if you're doing a T3, you have two tyrosine molecules, one with one iodine and one with two iodine.
Boom! Exactly. Wow. I'm shocked that you understood what I was trying to ask. But
I'm
that
like,
was
I
really good. Yeah, that's really good. Perfect. Thank you. Despite my best efforts, you still were able to answer that. So thank you. So yeah, you have one tyrosine that is one iodine atom, right? So that would be the T1, right? And you got one tyrosine with two iodine atoms. That's the T2, right? So one iodine plus two iodines makes 3. So that's where the 3 comes from, literally. It's a really, really basic. So Paula, building off of Natalie's mind reading, can you please tell us how you get a T4 precursor made within the thyroid?
So it's made the same way, but instead of joining one MIT and one DIT, you join 2 DITs, which come up to a total of 4 iodide atoms.
Perfect. Exactly. Wow. And you're even using like the technical terms. You guys are like, oh man, you're really throwing me a lifeline. Thank you. Yeah. So you're putting together 2 diiodinated tyrosines.
That's what they stand for. I don't remember that. Yeah, I just remember like kind of DITs.
Yeah. Perfect. So what exactly, Perlina, is colloid? Again, another vague kind of read my mind question.
Well, it's a collection of what's in the cell, so thyroglobulin.
Yeah, it's basically just a bunch of thyroglobulin, I guess is like the best way of thinking about it, which thyroglobulin in it of itself has a thyroid hormone precursor. So this is all just to build towards this wonderful picture that I found on Wikipedia, which is great for these kinds of things. we are going to walk through exactly how thyroid hormone is made. Okay, so basic diagram, let me walk you through. So you've got your nucleus, where you get transcription of the thyroglobulin protein, which eventually is translated in the rough ER, right? So you have the thyroglobulin, right? And as you'll see, remember, thyroglobulin is just a long protein that has a ton of tyrosines, 134 tyrosine, right? Because thyroid hormone is made of just tyrosine and iodine. That's it, pretty much. So thyroglobulin is exocytosed into, right? So we're looking at the thyroid follicle, right? So you've got the follicular cells ringing it, and then you've got this pink stuff in the middle, which is the colloid, right? So into the middle of this, outside of the cell, into the center of the follicle, you have your thyroglobulin, which undergoes a number of reactions. But essentially what you're doing, right? So you've got tyrosine here, and then you've got tyrosine here. But the difference is that now I've added iodine to it. That's what these little balls are supposed to represent. So we've got iodine that's been added here. And then you stick the tyrosines together, right? So this would be DIT, this would be MIT, right? Because there's monoiodinated and diiodinated tyrosines. So then you stick them together, and what do you get, right? So this would have, Sebastian, would this be T1, T2, T3, or T4? This one right here.
That would be a DIT and a DIP together. So that would be a T4.
Boom, exactly. Yeah, exactly. And Sharon, what would this be? T1, T2, T3, or T4? Precursor. Technically, it's not those things yet because you have to cleave it off, but the precursor to what, Sharon? I think Sharon may not be able to respond. So this is T3, right? So 1, 2, 3. Hyperthyroid hormone is actually really simple. Again, it's just iodine and 2 tyrosine. It's pretty crazy. And so then it goes back. So then TSH, what's not pictured here is TSH then, when it stimulates the cell, it endocytoses this, and then you proteolyze, right? You cleave the thyroglobulin, and then you release the tyrosine, or the T3 and the T4. Okay, so again, let's go down the list. So to make it really clear, Alex, so what is this thing right here?
Tyrosine molecule.
Perfect. And Alex, can you tell me how many iodines are on this thing?
2.
Perfect. And Catherine, can you tell me how many iodines are on this thing?
1.
This whole thing. Remember, so now they've been conjugated together.
So that's the whole thing. So that's T3, correct?
Yeah, exactly. There's 3 iodines.
3.
Yeah, perfect. Right. So it's technically not triiodothyronin yet because you have to cleave it off. This is technically, but this would be like a T3 precursor. So yeah. Again, this is not like endocrine. I love because it's pretty simple, honestly. Like it's simple and it explains a lot. Like it's one of the few things where like one theme can really apply to just about everything. So perfect. So next, let's go to Danielle. So Danielle, can you tell me again, repeat, what are the 2 major things that thyroid hormones are made from?
They're made from tyrosine and iodine.
Perfect. Tyrosine and iodine. Great. And so how exactly, Danielle, does radioactive thyroid ablation work?
I'm not sure. I'm actually not sure. I never really understood how the radioactive thyroid ablation works. Kind of just something I know.
I know. We know that we do it, but we don't know why. Can someone?
Yeah.
Can someone?
I need a
explain
lifeline.
How radioactive thyroid ablation works? It's like magic. You're like, oh yeah, there's this thing it ablates the thyroid.
Can I try this one?
Please.
I'm not positive, but
that's okay.
I think you give an iodine that is radioactive, like it's not a normal iodine molecule, and it's still going to get uptake by the thyroid. But since it is radioactive, instead of forming like T3, T4, it's going to actually cause degradation of the thyroid because it can't make any molecules out of it. So you're going to get a decrease in T3, T4 through that process.
Kind of. So you are correct that it is radioactive. You are correct that the thyroid takes it up. It's not like I actually think it probably is incorporated in, right? That'd be my guess. It's just like a radioactive isotope, right? So just like hydrogen is normally 1 neutron, but sometimes it can have 2 or 3. So it's the same, or I guess proton. Sometimes it can have extra neutrons for hydrogen. So in terms of iodine, so it's radioactive, so it's taken up, and it's just radioactive, right? It is releasing radiation to the immediate environs. And so you're taking advantage of the fact that, right? Because you'll use it in things like Graves' disease or hyperthyroidism, right? Where you're making too much thyroid. And so you want to destroy these things that are overproducing thyroid. And so it's perfect, right? This is the one place that you use iodine in your body. And so you can increase the amount or rather, if you give iodine that's normally taken up only by the thyroid, it'll be taken up by the thyroid, just like normal iodine is taken up by the thyroid. And then it will cause you to have damage to the thyroid. Perfect. So questions, does that make sense? It's a pretty brilliant mechanism, if you think about it. Just taking advantage of the normal uptake of iodine. And you just, it's kind of like a Trojan horse, right? They gave them that like Trojan horse, and then inside of it was bunch of guys, like soldiers. It's kind of like that. It's like you are putting something that is going to be bad for the thyroid into the thyroid, and you're ensuring that it only goes to the thyroid because the thyroid is the only thing that takes up iodine. So Elaine, can you tell us what medication would you need to take if you've had a thyroid ablation?
You would have to give thyroid hormone.
Yeah, exactly. Yeah. One of my church friends actually had a thyroid ablation, radioactive thyroid ablation, and she has to take that for the rest of her life. Yeah, because you've destroyed the thyroid, right? Like you did your job, but it will no longer participate in the HP, the hypothalamus pituitary thyroid axis. So what instructions, Elisa, would you have to give patients about medications or food if they're about to get radioactive ablation of the thyroid?
Okay, let me think. I think
you don't have to overthink it, right? Like what normally would, so you want to prevent, basically you want to maximize the uptake of iodine into the thyroid. How can you do that?
So would you say by decreasing foods that normally are salts that are iodinized?
Yes, exactly.
Okay.
Yeah.
Okay.
And why?
Because they would compete with the sodium, the Na iodide transporter. It's a transporter. Yeah,
exactly. Because it's essentially, I mean, at core, there are just competitive inhibitors of each other. Right? If the normal iodine is taken up, that means that's one other molecule or one other atom of the radioactive iodine that's not going to be taken up. Right? Essentially, right? It's not perfect like 1-to-1, but you can think about it that way. So yeah, exactly. Does that make sense?
Yeah.
Yeah. So this is a big deal because it's hard because like everything contains iodine, right? So you talked about like the iodinated salts, but like everything has like almost everything is iodine. So, right. So you're giving them radioactive iodine. If there's regular iodine around, then it will also go in through the sodium iodide symporter. And so then there will be less of the radioactive iodine that's taken up, right? Pretty simple. So instead, what you do is you tell them no iodine. And I don't know for how long, but it's for a bit. And the reason is because you essentially want to starve, because if they have less iodine, then it will increase the amount of iodine that it takes up even more, and there'll be less to compete to go in. And so if you reduce the amount of regular iodine, now there's even more radioactive iodine that will be taken up. So you'll have more radiation going to the organ that you want it to go to, and less radioactive iodine just floating around in your blood causing damage other places. So yeah. Cool? Make sense? We have a question about the difference between T3 and T4 and the role of T3 being more active while T4 is, yeah. So I don't want to go too much into this. I will say that so in general, what you need to know is that T3 is more active and that T4 is oftentimes considered like a pro-hormone. I don't know that there's much more that you really need to know for like these exams. Is there something specific, Jason, that you were wondering?
Nothing specific in regards to that. I guess from first and second year was kind of drilled in our head, like, oh, T3 is an active one. T4, there's more of it. And just trying to differentiate or just learning what's really, I don't want to be very general, but the big deal between the two, aside from that, is kind of what I was trying to drill down a little bit more on, because that's like basically.
So when you get to like the nitty gritty, so my mom is hyperthyroidism. I don't think she would mind me saying this. So my mom is hyperthyroidism. What's interesting is that like, this is something you didn't know in medical school, but like she basically has to take T3 and can't take T4, because normally when you give someone thyroid medications, you have to give them T4, or like that's like the standard is to give them T4, the thyroxine, right, as opposed to triiodothyronine. So for some reason, some people, and this is I guess established in at least a small amount of the literature, that like because it gets more complicated, but like the conversion of T4 to T3 happens oftentimes peripherally, right? So not in the thyroid.
Okay.
And so apparently there are different conditions, or some people just don't convert it as effectively or whatever, but there's a subset of the population who do not effectively convert T4 to T3. And so it becomes relevant because like for some people, they will still have signs of hypothyroidism, even though they would have what seem to be normal levels of T4. So,
Okay. All right. That makes sense then. Okay.
but like in terms of that's like I didn't even learn that in med school. I just did extra reading because my mom was like telling me about like I need T3, and I was thinking like, oh, is this real, or is this like one of those things where patients tell me I need like brand name medications only? Like, is this just like one of those things in your head? But no, there's like actual literature behind this. So I don't want to poo-poo.
Okay, so basically don't read too much into it. Then just kind of know T3 versus T4 and kind of leave it at that, just for board wise.
For boards, T3 is the active one. I'd say that's what you need to know. Yeah. If you wanna like make people like my mom really happy, then you would understand that there's a little bit more than what's taught in medical school, in that not everyone can convert T4 to T3 effectively.
Okay, yeah, I think maybe in my physiology class there might have been some talk about that, and I just have foggy memory on it, so I just knew there was something there.
Yeah, that's
okay,
mine. Yeah, of course. All right. So next, other questions before we move on to talk about thyroiditis and the difference between hyperthyroidism and thyrotoxicosis. So let's go to Luis next. So Luis, can you tell me what exactly is the difference between hyperthyroidism and thyrotoxicosis? A common misconception in medicine.
Okay, so hyperthyroidism is basically high thyroid hormone level, in this case, T3 and T4, because of an overproduction of those two hormones. Overproduction.
How about thyrotoxicosis?
It's also high levels of thyroid hormones, but I think it's high thyroid hormone levels, but it may compromise your life, or there's an evidence, kind of like a storm, or it's too much thyroid hormone that can lead to a...
So it's actually, interestingly enough, so the difference is, so you were right about the hyperthyroidism. So hyperthyroidism means you have high thyroid hormone levels because you're overproducing it. Thyrotoxicosis doesn't mean that it's like, it sounds like, oh my God, I'm gonna die, like thyroid storm, something crazy like that, but it's actually not. Thyrotoxicosis just means I have high thyroid hormone levels just for any reason, right? So in other words, hyperthyroidism is a type of thyrotoxicosis. Right? It's a specific type of thyrotoxicosis, right? So if I took high, like exogenous thyroid levels, I would be thyrotoxic, but I wouldn't be hyperthyroid. I'm impressed that you knew that hyperthyroidism was because of overproduction. There was a senior, when I was a first-year medical student at Stanford, there was a senior lecturer who like swore up and down that hyperthyroidism just meant that there was higher thyroid hormone levels. And I was like, well, okay, so then what does thyrotoxicosis mean? He had like nothing to say, because this is a very misunderstood concept. But very simple. Hyperthyroidism means high thyroid hormone levels because you're making too much. Thyrotoxicosis means I just have high thyroid hormone levels. It's a variety of causes. So Maliha, what would be an example of hyperthyroidism?
Graves' disease.
Oh yeah, perfect. And how about Manny? What would be an example of thyrotoxicosis?
That would be taking like exogenous thyroid hormone.
Perfect. Can you give me another example?
Sorry, I'm not sure.
Okay, that's okay. So another example would be, taking too much thyroid hormone, certainly. Another would actually be thyroiditis. So inflammation of the thyroid gland.
How does that work?
Ooh, I am so glad you asked, because that's going to be our next slide. So remind me, Marco, what exactly is thyroid colloid?
Thyroid colloid. It's a collection of thyroglobulins.
Yeah, it's just a bunch of thyroid globulin, which has the thyroid hormone precursors, right? So Marco, can you tell me, how could thyroiditis lead to thyrotoxicosis? How does that make sense?
Oh, it's an inflammation of the thyroid. So if the inflammation leads to great storation of thyroid hormone on the gland.
Yeah, exactly. Yeah, essentially. So the idea, right? So unlike other organs, the thyroid gland stores a ton of thyroid hormone, right? I mean, other organs have a little bit in vesicles, but the thyroid hormone, it stockpiles thyroid hormone in the form of the thyroid globulin that makes up the colloid, right? And so when you get inflammation, I don't know why. I assume it's because of because like you have proteases in neutrophils and macrophages and stuff, right? So I presume that some of those proteases can cleave T3 and T4 and release it, but that's like a hand-wavy explanation. But the idea is that you have inflammation of the thyroid, and you can see actually that the colloid just like disappears. And the idea is that you're basically just depleting the colloid because you're cleaving it and you're releasing all that stored thyroid hormone into the bloodstream. That leads to thyrotoxicosis. Okay. Cool. Does that make sense?
Yeah.
Yes, it does.
Okay.
Yes.
So Mashoud, what would the TRH, TSH, and T3-4 levels be in someone who had thyroiditis? An early thyroiditis, and why?
Okay, so in early thyroiditis, I'm thinking, okay, so because you said the thyroid has a lot of thyroid hormones, it's inflamed, so that means there's a lot of release of the hormones. And then, so if I'm releasing a lot of thyroid hormones, I'm releasing a lot of T3 and T4. Perfect. And then going back to the hypothalamus pituitary axis, if I have a lot of T3, T4 due to negative inhibition, I believe that will decrease TSH and TRH.
Yeah, exactly. Perfect. Yeah. Again, it all just comes back to feedback inhibition, right? Like as long as you understand the HP, end organ axis, and the hormone decreases activity of the H and the P, in other words, the hypothalamus and the anterior pituitary, everything just makes sense. Yeah. So your T3 and your T4 would be high. You have inflammation, release of T3 and D4. That is going to feedback inhibit the hypothalamus and the pituitary. Boom. Yeah, exactly. So Natalie, in someone with late thyroiditis, what would the TRH, TSH, and T3, T4 levels be, and why?
I would think that in early thyroiditis, you kind of release all of your T3, T4. Maybe in late thyroiditis, you wouldn't have as much stored up, so then that would decrease. And then that decrease would lead to, you wouldn't have that feedback inhibition on TRH and TSH. So then those two levels would be high.
Boom. Nice. You're ready.
I hope so.
Yeah, that was good. That was really good. Yeah, exactly. Again, this is the kind of rationale that you need to be able to do on the spot on your test. That's it. That's all they're asking you to do, is to reason through it, to use your knowledge to reason through a situation that maybe you haven't seen before. That's it. That's all they want. They want you to be able to use it. They don't want you to memorize it. So good. That's good. So yeah, the problem is that you've released all of the T3 and the T4, and it's been degraded in your body like all hormones eventually do. But because the thyroid has had too low of TRH and TSH for too long, you haven't replaced it. You don't have it. And so now you have too little thyroid hormone, which causes disinhibition of TRH and TSH, which causes an increase in TRH and TSH. So in early thyrotoxicosis, the problem is that we have an increase, right? We have a release of all that colloid, all that stored T3 and T4. That's going to cause increase in inhibition of the hypothalamus and the anterior pituitary, which is going to cause a decrease in my TRH and my TSH. Perfect. And we can probably end on this. So Paula, how exactly does radioactive iodine uptake work? And how is it used specifically for the diagnosis of thyroid pathology?
What was the first part?
How do you use radioactive iodine uptake to diagnose thyroid pathology?
So I think from what I remember that when you want to see that the thyroid does take up the iodine, and so you can visualize that through giving the person radioactive iodine and visualizing it through some kind of machine that detects that. And so if the thyroid gland isn't working, it won't uptake the iodine you gave the person, and you would see you wouldn't see it in the imaging system you're using. Is that right?
Yeah, essentially. So saying if the thyroid gland isn't working is a little vague. I guess I would say specifically, if you're not actively making thyroid hormone, then you wouldn't take up the radioactive iodine. But yeah, otherwise that's exactly it. So you give radioactive iodine, right? So it's like in the case of radioactive thyroid ablation, right? It's radioactive iodine, but in this case, it's different in the sense that it's the radiation that it emits is not like really toxic like the other kind of radiation. They do that by just having a different isotope that they give. And so it goes to the thyroid gland, and if the thyroid gland is making thyroid hormone, it'll take it up. If the thyroid, if it's taken up, then it'll decay, and then you can use a nuclear medicine scanner to see how much and where the iodine was taken up. It's pretty cool, right? So let's look at what this would look like. So I got this image PLOS paper, which was referenced actually in Wikipedia, which is, again, a great place for finding a lot of these things. And so what you do is, so you've given someone radioactive iodine, it goes to their body, again, because the thyroid is the only place that's going to use that iodine. If the thyroid is making thyroid hormone, it'll look like this, right? So all of the cells have taken up that iodide, and so the iodide is sitting in those cells, and now it decays. And as it decays, right, you can use essentially like a Geiger counter to look at where the decay is coming from and how much there is. Okay. So normal would be A. B would be this would be like Graves' disease, right? So you can see how there's more of all of this everywhere, right? So this would be like Graves' disease. C would be, Perlina, do you know what C would be?
Oh, sorry.
This is a hard one.
Is it like thyroiditis?
No. So thyroiditis would be like, we'll talk about that. Thyroiditis would be E.
Okay.
But C would be like a toxic multinodular goiter, right?
Okay.
There's many nodes that are overproducing thyroid, right? But if you think about feedback inhibition, right? So you're making a ton of thyroid in these nodes. You'll notice that the other parts of the thyroid that aren't dark, they are actually lighter than normal. And that's because so these are independently producing, so also known as hot nodules, right? These are overproducing thyroid hormone, which is going to feedback inhibit TSH and TRH, which is going to cause for any cell that will still respond to TSH and TRH, meaning basically any normal thyroid cell, you'll have a decrease in production. So that's why it's actually darker in the other areas, which is also what you see in D, right? So D is just one big hot nodule. This would be like I think it's like an adenoma, like a thyroid adenoma. It's just a nodule that's producing too much thyroid hormone. And so again, you'll see that there's little production everywhere else. E is thyroiditis. Can someone explain why E would be thyroiditis? Or Perlina, if you want to give it a shot. So
Well, you're
Perlina.
making less thyroid hormones.
Why?
So it's not going to be as dark.
Yeah.
Because, yeah. So you're making less, in thyroiditis, you're making less thyroid hormones. So then you won't take in as much of the radioactive iodine.
Yeah, exactly. And why are you making less thyroid hormone?
Because it's thyroiditis, because it's inflamed. So you release more than it'll die down.
Yeah. So walk me through again. I want you to use the concept of feedback inhibition. That is if there's like one thing that you learned from today, it would be feedback inhibition. That's like the key concept in all of endocrinology.
Okay. So with thyroiditis, you're initially releasing more thyroid hormone, which is inhibiting the TSH and the TRH. So those would be low. And then as time goes on, you're not making more of the thyroid hormone. So the levels would decrease, which would stop the inhibition of the pituitary and the hypothalamus. So your TSH and TRH would increase.
Yeah.
To try and make more.
Eventually. Yeah. But in this case, this would be like early thyroiditis, right? So what he's describing in the beginning, where you have release of the T3 and the T4, which will cause, like you said, a decrease in TSH and TRH release, which means that you will be making less thyroid hormone. And again, thyroid hormone is just tyrosine and iodine, right? So if you have less TSH, you're going to be taking up less iodine. So you're going to need to make less thyroid hormone. So yeah, so that's why you don't see it really dark. It's minimally dark. You can kind of barely see the hazy sort of outlines. Yeah, exactly. Well done.
Thank you.
So Sebastian, tell me, we kind of already talked about this, but use the underlying pathophysiology to explain how the labs would look in the early part of the disease for Graves versus subacute granulomatous thyroiditis.
Okay, by limiting. So I think in both the T3 and T4 will be high.
Good.
Meaning that if we measure the TSH and TRH, they will be low.
Good. Yeah, exactly. So how would you know? How could you tell the difference, right? Or similarly, right? What if someone was taking like exogenous thyroid hormone? How could you tell the difference?
By doing a radioactive iodine.
Ooh, interesting. And what would that tell you? How would you be able to tell by using radioactive iodine?
Well, it's great disease. Okay, if you're taking exogenous thyroid hormone, your thyroid is not making the thyroid hormone, meaning that there will be less uptake of iodine, so less reactive and less painted in the nuclear scanner, right?
Perfect. Yeah, exactly. How about Graves?
In Graves, there's an autoimmune disorder telling your thyroid to make more T3 and T4, meaning that the uptake will be higher. So there will be more activity in the thyroid gland.
Perfect. Yes, exactly. Perfect. Yeah. So this is, again, a very important concept to know. They love to test this on step 1, right? So the early labs would be identical. TSH would be low, TRH would be low, your free T3 and your T4 would be high. However, right, because you have the thyroid stimulating immunoglobulin, right, the antibody against TSH in thyroid disease, in Graves' disease, you're making more thyroid hormone. So you would have more radioactive iodine uptake. It'd be high, right?
Right.
See here, right? So it's high. You're making more. Whereas in the case of thyroiditis, you're making less thyroid hormone, right? Because in this case, there's low TSH, and you don't have something that's telling your thyroid to make more, like an antibody against TSH, the TSH receptor. So your radioactive iodine uptake would be low. Yeah, exactly. So that's why thyroid, so even though the labs would be the same, right? High T3, T4, low TRH, low TSH, between Graves, B, and thyroiditis. In the case of Graves, it's because you're actually hyperthyroid. You're making too much, right? So you would have a high uptake. And in E, you're not making any. You're making much less. And so you'd have low radioactive uptake. This is a very important concept for your test. All right, perfect. So I am going to end this here. Questions, comments, concerns before we wrap up. We'll do more next time.
Alec? I just have a quick question. You said in Graves' disease, TSH would be low. Is it endocrine? Because I'm thinking, I don't know if I'm thinking wrong or something, but if you have TSI, wouldn't is that stimulating TSH directly or?
No, it's a receptor.
Okay.
It's basically as if the receptor it thinks that there's high TSH, right? Because you have an antibody it's a weird antibody, right? Like normally you think of antibodies as causing a dysfunction. In other words, it causes it would block the receptor so that it doesn't work. In Graves' disease, the antibody actually causes the receptor to work, right? So so your body thinks that TSH is high because you have these antibodies binding to the TSH receptor, but your TSH is actually low, right? Because you have feedback inhibition from the high T3 and T4 that you're making.
Oh, okay.
Does that make sense?
Because I thought TSI directly stimulated TSH.
Yeah, no. At least I'm pretty sure, unless someone corrects me, I'm pretty sure that TSI is against the TSH receptor specifically. And so if it's against on the thyroid gland, so it stimulates the thyroid gland. It's basically like an independent mechanism of stimulating the thyroid gland. That's not TSH. And so you overproduce T3 and T4, and the overproduction of T3 and T4 will cause a decrease in TSH and TRH. Natalie says that's correct, and she's taking her step 1 in a week and a half, so it's got to be correct.
Right. All right. Thank you so much.
Yeah, of course. Other questions?
Yeah, like really quick.
Yeah.
So thyroiditis can be summarized by, so there's an inflammation, meaning that the follicular cells will be separating. So the content in the colloid would leak out, meaning that more T3, T4 is at the bloodstream.
I guess so. I don't know exactly why it does. I know that it does. I would have maybe it's like you said, it would make sense that it was like leakage out, like you get edema into cells, like leakage of the colloid in between the cells. Certainly plausible. I don't actually know if that's true. But if you look at look at a picture of Hashimoto's or thyroiditis sometime, look at histology pictures, you will see that the colloid, right, instead of being this plump pink thing, it looks like raggedy and it's all gone.
Okay.
So I don't know. The way that I make sense of it is that so you think about emphysema. Right? Emphysema is driven by inflammation. So you have neutrophils that go to the alveoli and they release proteases, right, which break down protein. And so they break down the elastin and stuff like that, like proteases, elastase. So the same thing is true for inflammation of the thyroid, presumably. So you could have, inflammatory cells, which I guess I presume would release proteases, and those proteases could cleave, again, the protein, thyroglobulin, which would release T3 and T4. That's a hypothesis. I don't know if that's true. What I do know though is that you have less thyroid colloid, and yeah, it happens presumably because of inflammation.
Okay, thank you.
Yeah. Other questions? These are good questions. Great questions. Marco.
I have one, please. There's a situation that is called subclinic hypothyroidism.
Oh, yeah.
It's a tough thing. I don't know if it's really asked on the step.
That's step
situation.
one. Sometimes maybe step two.
Yeah.
I don't, to be honest, I don't really
Think about that.
subclinical. Yeah. I don't actually, let me look that up and I'll give you a better answer next time. It never really made sense to me, honestly. If you have the answer, please tell me. But I don't want to, I want to, give me I will look it up, but give me a chance to give you a better answer. I don't want to lead you down.
Yeah, I'm asking you that, but just afternoon, I've seen a patient that she has a diagnosis of hypothyroidism because of Hashimoto's disease, but she's taking the thyroid hormones, the T3, the T4, but he still has a few symptoms like fatigue, like edema at the lower limbs, but she has good results on
all of her lab
tests. Okay, so she's taking the medication. She has a good results on the lab, but she still has some symptoms. That's our lesson today really called her. Sorry, this afternoon.
I don't know. Yeah, I don't know. I mean, I'm by no means like an endocrinologist, but I don't know. I mean, is she taking T3 and T4 or just T4?
No, just T4. Just T4.
So it could be like my mom. I don't know. It could be like my mom. She may, because again, the problem is that we measure T4, right? Usually we measure free T4, even though T3 is the active one. So it's theoretically possible that maybe, I don't know. Let me look up subacute or subclinical hypothyroidism more.
Okay.
But I guess one thought would be maybe it's that you can't just give T4 to people that are hypothyroid.
All right.
So that's a possibility.
Mm-hmm.
Good question. Other questions, thoughts, concerns? All right. So I always like to, I mean, even in college, or high school, I always really liked to understand the applications of what I was learning in real life and sort of see connections between things. So it was something I learned about in college about like banana seeds, or like why bananas don't have seeds. And that it's really interesting because it actually ties in really nicely with Turner syndrome and with Klinefelter syndrome. So I want to talk about that just because I think that it's important and interesting to be able to make connections across different things. So whenever I create these lectures, I always base them around integration and application questions. My goal with this is twofold. One is that this is exactly the kind of information, the kinds of things that you're going to be asked in your exam. So obviously, step one is no longer just, you memorize a fact, and it's not like med school exam where you just read something on a PowerPoint slide and can regurgitate it on your test. Step one is much more, can you see the connections? Can you apply what you've learned in a clinical situation? And so these are exactly that. They're applied questions. The other reason why I like these sorts of questions is because if you can answer these questions, you'll basically understand the majority of the information in this lecture without having to go back and necessarily review it specifically. Just like with the biochemistry questions, I start with questions like, why do you get really red venous blood in carbon monoxide poisoning, or in cyanide poisoning rather, or things like, why do you get a fasting hypoglycemia in binge drinking when you've been fasting? If you can understand those questions, you don't really have to sit there and memorize the pathways. By virtue of the fact that you can answer the question, can apply it, it means that you have to understand it at a deep level. So all of these questions, so what stage of the cell cycle will you arrest when you give someone vincristine? How can you use the mechanisms of creating seedless bananas to understand the classic gonadal findings in Turner's? What's the height of someone with Klinefelters and why? And what's the ultimate height of someone with precocious puberty? All of these things, if you understand them, you'll understand sort of the basics that you need to know as well for your exam. Sound good? So let's talk about gametes. So what exactly is a gamete? All right, how about Sherry?
Gamete is, my understanding, is haploid germ cells or sex cells.
Yeah, exactly.
Yeah.
So yeah, I said haploid here. So basically just haploid germ cells, they can form together with another one of the different sex in sexual reproduction to form a zygote. I guess the only caveat would be that it's not always haploid. I know that I said haploid here. For us, they're haploid, but if, let's say that you're triploid, or if you're like tetraploid, then it's not necessarily going to be haploid.
Yeah, in general.
In general, it's haploid. For diploid organisms, a germ cell would be haploid. So in humans, what are the gametes called? Natalie?
I think
They're like the sperm and the ova.
Perfect. Yeah, exactly. And how many chromosomes are there in a normal human cell, MJ?
46.
46. Perfect. So it's one pair, right? So it's a diploid organism, meaning there is two sets of essentially, or two sets of the same chromosomes. So there's 23 different distinct chromosomes, and there's two of them. So how many chromosomes would there be in a human gamete then, Lindsay?
23.
Perfect. So it'd be 23. Excellent. So it's just one set. So like we said before, haploid. So meiosis. So what's the process that's called in which we form gametes? So meiosis. Describe the general process of meiosis. Who wants to give a stab at this? Let's go with Manu.
So meiosis, like you said, is the process by which we make gametes. It consists of two cell divisions, meiosis 1 and meiosis 2, and the end result is that you make haploid cells.
Yeah, good. So you got one parental cell, right? So it goes, you get a parental germ cell, so it's got 46 chromosomes. You go through the S phase, so you're doubling the number of chromosomes. So you had two sets, now you have four sets. And then through, as Manu said, two separate cell divisions, you now form four different cells. So one cell becomes two, and then the two cells become four. And each of those cells now has a single haploid genome. So how many chromosomes would be in each daughter cell? We already talked about this, 23. So how many cell divisions would this undergo? We just said two. So meiosis 1 and meiosis 2. So Manu, do you want to walk us through just generally what happens in meiosis 1?
Okay. So, you have the mnemonic PMAT, which refers to the four phases of meiosis 1, prophase, metaphase, anaphase, and telophase or telophase. So in prophase, you will have the chromosomes condensing and you have the nuclear envelope breaking down. In the metaphase, these chromosomes will align at the equatorial plane of the cell, and then you have them being pulled apart to the polar ends of the cell, and then you have telekinesis, where you have reformation of the nuclear membrane, and you have cytokinesis, which is the division into two daughter cells.
Perfect. Yeah. So I guess the major points that I'll point out in addition to what Manu was saying was, again, you're starting with basically you're starting with four different sets of chromosomes. So you can kind of see that here, 1, 2, 3, 4. And so the first thing that happens, so in meiosis 1, all you're doing is you're separating out. First, what you have crossover, right? So crossover happens where this is how you get, it's so that your gametes don't have your chromosomes don't have the exact information of the parental, right? So the chromosomes exchange information so that you can get some genetic diversity. And then you're separating it out so that you have the pairs of chromosomes that are being separated from each other. Cool? Meiosis 2 is essentially the same thing. It's just you're separating out the pairs. So you start out with two of each chromosome, and now they're separating out into so that each cell has a single set of chromosomes. What questions do you guys have? Because I know that for some of you, for most of us, it's been like years and years and years and years since we had to think about this in any sort of serious way. I will say it is rare that they would ask you a question directly on one of the phases, like knowing, that metaphase is when they're like lining up or something like that. They're unlikely to ask you a question like that. They're more likely to ask you questions that we'll talk about in a second. But before we move on, what questions do you guys have?
When does crossover happen? Which phase
great question.
is crossover?
So metaphase.
So metaphase. And if we're trying to tie it to the reproductive system, I guess before puberty, the ova is frozen in prophase 1, right? Then eventually it becomes metaphase 2, but I'm not sure how to put that into that process.
Oh, good. Great question. So what Vin is referring to is his question, that's a great question, is you are developing, you're sort of going through the process of creating the eggs. And so I think, can someone explain? Who wants to give that a shot? Manu, what do you think?
Oh, sure. Okay. So is Vin asking how the eggs develop from the oocytes? In which phase does you transition from being frozen from prophase 1, and then eventually it becomes metaphase 2, but I guess it happens just before. I'm not sure when it transitions into metaphase 2 when it's frozen in metaphase 2. Oh, okay. Yeah, so you have, from the way I understood it, you start off with your oogonia, or I guess that's how you call it. Then you go through meiosis 1, and then you get something called a primary oocyte, which is going to be stuck in meiosis 1 until puberty. And then at puberty, you start pushing one every month into the second phase, where it goes under the second division. and then that's arrested in metaphase 2 until fertilization. Okay, gotcha. So one of them develops, and every other follicle degenerates. Only one develops, and you say that every month that follicle, which is the most mature, is the one that gets arrested metaphase 2 until fertilization, right? After just a few days after ovulation. Yeah. So like the key thing, like the way is like to get the primary oocyte, you hit that in fetal life, right? So the fetus is going to have the primary oocyte done, and during a woman's ovarian cycle, you take their primary oocyte and you push it to the secondary oocyte. And then after fertilization, that's when you finish the whole process. I don't know. Yeah,
That's good. That's very good. The way that I tell if someone understands something well is if someone doesn't understand the topic very well and then is able to answer questions based on the explanation afterwards. So do you guys feel comfortable that you would be able to answer questions on this, or is there something you'd like to clarify?
When we were talking about the 4 sets, I remember something like, okay, you have the 23 chromosomes, right? And then you duplicate it during the synthesis phase. My question here is, like, I remember it like being when it's duplicating, it's like, like how there's one stick connected to the dot and then there's another stick. You get what I'm saying? They represent it like that. And then when it doubles, you have 2 sticks connected to one dot and there's connected to the other 2 lines. You get what I'm saying?
I think so. Kind of like these pictures.
Yeah, so when it synthesizes, when you're saying like it doubles, you have one of the chromosomes being still attached to that single centromere point, right?
Oh, you're saying like how is it represented? I don't know. I honestly don't know. I mean, yeah, I think so. I think it's like an X, and then the X now becomes like a double X, like you see here.
Yeah, that's what I'm saying. Okay, cool. I got it. So then now that it's 4, and then meiosis 1, you basically divide those 2, and then meiosis 2, you divide the ones that are dividing that's being held together by the centromeres.
Exactly.
Okay.
Yeah.
Got it.
Okay. So again, I think that I wouldn't worry about too much. I'd be surprised if that came up on any sort of medical related test, at least at the national level. So I want to focus more on like big picture stuff. So what are the steps in mitosis? Let's go with Liz. What are the steps in mitosis?
So I haven't done this in a really long time, but I know that you have one cell, right? One like mother cell, and it's divided into 2 daughter cells. And let's see, I think it's pretty much the same as meiosis 1.
Yeah, exactly. That's the exact same. Prophase, metaphase, anaphase. Good. So what's the difference between mitosis and meiosis? Because they're pretty similar, right? The steps are the same. Can you tell us what's the difference between mitosis and meiosis?
So in mitosis, you end up with 2 like diploid cells, and in meiosis, you end up with 4 haploid cells.
Perfect. Exactly. Yeah, that's exactly it. Basically, it's the number of cell divisions. Mitosis is just 1 cell division. And so because you have, you go from having 4 sets to 4 different sets of chromosomes having 2 sets of chromosomes. And then in meiosis, you're doing an additional division. So you end up with 1 extra division. So you have only 1 set of chromosomes. So perfect. It's the same number of chromosomes overall. It's just in one case, it's split across 2 cells in mitosis. In meiosis, it's split across 4 different cells. So integration question number 1. So in Christine, at what phase in the cell cycle would you arrest? And why would that make sense?
Metaphase?
Metaphase.
Mitosis?
Yeah, mitosis. Yeah, basically. Yeah, good. So yeah, probably metaphase, but I meant like cell cycle, in terms of S, G1, M, G2, those. Or G1S, G2M. So we would arrest at M. So why in the M phase?
Interferes with the microtubule.
Right.
Sorry?
So basically you
Interferes with the
polymerize.
formation of microtubule.
Go ahead.
Yeah. So the vincas and taxanes, in a very big picture sense, affect microtubules. They inhibit the function of microtubules. So if we go back, right? So so again, this says meiosis, but the steps are almost identical in mitosis. The centrioles, so these things at the poles that Manu was talking about before, are attached. They themselves are microtubules. They attach via microtubules to the centromere in order to pull these chromosomes apart from each other. And so if I have a drug that inhibits microtubule function, then I'm going to block the ability to have separation of these chromosomes. Does that make sense? So this is, the basis of using vincas or something like vincristine or vinblastine or taxanes for cancer. Because again, the general idea of cancer therapy, at least before we developed targeted therapies, was because cancer cells were thought to divide more rapidly than all the other cells. If we could target all cells that divided rapidly, we would proportionately kill cancer cells. That makes sense. And so if things that are undergoing a lot of mitoses are going to be more prone to damage or to being affected by things that affect microtubules. Does that make
I
sense?
have a question.
Sure.
Yeah. Isn't it more accurate to say it's arrested in the prophase 1 phase? Like my question here is, doesn't
I
like
actually
how do
don't
you
know.
how do you like is how do you like get it in the like sorts of equatorial
Yeah.
plate anyway in the first
That's a
place?
great
You need
question.
macrotubules for
That is,
so
I think,
wouldn't it be-
beyond the scope of what you might be asked. I personally
just-
do not know. What you're saying makes sense, but I don't know. It's not a trivial question to answer. Although, yeah, I'm sure it's known. I'm sure that particular thing is known. I don't know the answer. Good question. Perfect. Okay. But again, these are the kinds of things that you guys are going to want to think about. These are the kinds of ways that they're going to ask you these questions. And again, if you can understand the answer to this question, there's a lot of things that you will inherently understand about cell cycles and about mitosis and meiosis. All right, so let's talk about banana seeds. I actually thought this was like super interesting. And this is something I learned in college, but didn't really fully grasp until I had to like read up a lot about this over the past week and a half. So what are the gametes in fruit and like bananas or in fruit? I'll be impressed if you guys know this.
Ovules and pollen.
Nice. Well done, Chris. Did you read the PowerPoint?
Yeah, so the ovules are the female equivalent, so they're kind of like ova, and the pollen are kind of like sperm. I looked it up prior to this lecture. I thought it was interesting.
Yeah, I think it's like super cool. So then what's a seed?
It's kind of like the zygote. When the ovules and the pollen come together, then you make a seed.
Love it, man. And I love that. I want to point out specifically that you made an analogous sort of connection with like humans, right? So I love that you're like, oh, it's basically like a zygote, which is exactly what it is. That's fantastic. I think they even call it, there's like an embryo phase too. I mean, like they even use similar terminology. But yeah, it's like the zygote. So it's when you combine the pollen and the ovule. So what happens if a seed does not have a full set of chromosomes? If that zygote doesn't have a full set of chromosomes?
And it dies.
Yeah, exactly. It just dies. In humans, what occurs if a germ cell doesn't have a full set of chromosomes?
Same thing.
Yeah, it also dies. Right?
It's interesting.
Yeah, which is like super cool. Integration question 2. So why do commercially grown bananas lack seeds? And so it's funny, I read an article on, it came up on, it showed up on Apple News actually on my iPod. And I was just, it was like, you know, bananas may grow extinct or with some sort of equivalent title. And one of the reasons is because bananas don't have seeds. So there's no genetic diversity. It's like coffee, right? There's like no genetic diversity. It's like a single kind of plant. And so if, you know, there's some bug or something that can attack that plant, then like the world's banana like crops are just going to get hosed. So were we in this situation? Why do bananas lack seeds? It's kind of cool.
Because it comes out with an uneven number of chromosomes.
Okay, but why would they come out with an uneven number of chromosomes?
Maybe there's a problem with meiosis.
It's not necessarily a problem with meiosis. Tell me what you mean with problem with meiosis.
There like non-disjunction going on.
Yeah, I was thinking something like, you know how we see something in Down syndrome, you get like triploidy.
Yeah, exactly. So it's not necessarily non-disjunction, because non-disjunction implies that you have two chromosomes. I mean, it kind of like non-disjunction. So
Is it possible that it has the same mechanism as like, you know, like what's called like a complete mole or a complete
That as well. Yeah.
Yeah. So think about it this way. I think that maybe the easiest way to think about it is if you have two sets of chromosomes, it's really easy to split those into two different cells, right? One set's going to go on one side and the other set's going to go on the other. But now let's say that you have three sets of chromosomes. How are you going to divide that evenly between two cells? You can't, right? So some cells are going to have more chromosomes of one and the other cell is going to have more chromosomes of the other. In order to form a seed, however, I actually have to have a full complement of chromosomes. So I would have to have the pollen have gotten two chromosomes from one and one chromosome from the other. And then for chromosome 2, it would have to have one chromosome from, you know, the mother and then two chromosomes from the father. So that every single chromosome, right? So humans have 23 different chromosomes. So if bananas had 23 chromosomes, every single one of those chromosomes would have to have three separate copies. Statistically speaking, that is just so unlikely that bananas just don't develop seeds because the probability of having a pollen and an ovum that have the exact complements of chromosomes to form like a full set of chromosomes is so low. So they just don't have seeds. And that's why you can eat a banana and just not have to think about spitting out seeds or anything. It's kind of cool.
Yeah.
When I read that, I was like, man, That's amazing, right? That's the next thing
Yeah.
about banana. Same thing with I read that they do you guys know how they make seedless watermelon?
Yes, I was just thinking about it because I had it the other day.
Yeah, they're not triploid, or they are triploid, but it's different. So seedless watermelon, what they do is they basically cross a tetraploid with a diploid. So watermelons, I guess, are normally diploid. So like us, right? 2 sets of chromosomes, but they somehow genetically alter them so that they have a tetraploid strain, and they'll cross the tetraploid with the diploid. So they'll essentially create for a single generation a triploid watermelon. But again, it's the same thing. They're ovum, like the likelihood that you will form seeds because you have that they'll have a full set of chromosomes is so exceedingly low that they just never develop seeds. Isn't that cool?
Hey, Alec.
Yeah, what's up?
If I ate a wild banana, how big are its seeds? I don't know
That's
if
a
I've
good
ever had a
question. I
wild
didn't
banana.
have time to look that up, but that I'm sure you could Google image that. But I do not.
Okay.
Yeah,
Okay,
that's a great
thanks.
question. I was like, you'll see later. It took me so long to figure out like the mechanisms of street gonads. There's like so many different proposals. I literally was reading like primary research from the 1960s. There's like review articles. I was like, wow. It's a good thing that like I didn't ask you guys to do this because it took a long time, but it was cool. Excited to talk about it. But yeah, I don't know. Monitors just sent us a picture. Are these the banana seeds?
Yeah, they look insane.
Oh, that's crazy. That's cool. Yeah. All right. Oh my God, is that a banana?
Wow.
Okay. So how can we use this to explain how you get streak? So actually, before we talk, what is Turner's? Can someone tell me what is Turner syndrome? It's actually not, sorry, I shouldn't say Turner's. It is actually Turner syndrome.
I think that it's only when only one X chromosome, right? And then
exactly.
nothing
So
else.
But that can be mosaicism as well.
Yeah, you can have mosaicism as well, but the classic is XO. Like the one that you should know about is 45XO, meaning instead of having 46 chromosomes, you lack one chromosome. So what would be a mechanism for developing streak ovaries in Turner's?
I thought it was because you were missing an X chromosome from your paternal DNA.
Okay, true. But why would you get streak ovaries? So that's how you get XO in the first place. So like if the sperm doesn't have an X, then if it combines with an ovum that does, I mean, it could presumably happen from either.
They don't have enough estrogen?
Nope. There's a number.
You need like both of the X chromosomes.
Sorry?
Like you didn't need like both the X chromosomes to develop a fully functional ovary.
Yes, exactly. And why might you need both X chromosomes to develop a fully functional ovary?
Isn't it true that one of them is inactivated or something like that?
Let's talk about that. So that is I'm glad that you brought that up because we are going to talk about that. So that is true for somatic cells. That is not true for cells. And that is actually something I did not know until I read these articles from not something that's emphasized in medical school classes. At least it wasn't at Stanford. Manu, what do you think? Do you have an idea? Or it could be someone that read the presentation. I honestly wouldn't have known this until I had to look it up. So there's a lot of different mechanisms. And again, because we're talking about essentially human embryos, because it's like we're talking about ovarian development in embryo basically. So I don't know that we'll ever have the exact answer because it's really hard to study this sort of thing, as you might imagine. But one idea is that you need germ cells, like the germ cells, you need the ovarian germ cells in order for the ovaries to develop properly. And same thing with the testes. You need the germ cells in order for them to develop properly. They've done studies where they basically ablated the movement of germ cells to the gonadal ridge, and they looked exactly like streak ovaries, right? So in other words, in order to get full development of the gonad, so the ovary or the testis, I need germ cells present. So then the question is, how could I lose the germ cells? So just like seeds, if they don't have a full complement of chromosomes, if germ cells don't have a full complement of chromosomes, they will also undergo cell death. So it's kind of weird because you can form like a zygote with only having one X chromosome, but the germ cells themselves seem to need an exact number of sex chromosomes, which again seems odd. We'll talk about in a second why that is. But again, the problem is that you are not naturally going to form a daughter cell that is going to have the exact number of chromosomes, right? If I start with one X, I'm not going to suddenly develop two X's unless there's some sort of non-disjunction event. So I don't get germ cells. If I don't get germ cells, I don't get ovarian development, and they look atrophic, right? So they just look really small. Does that make sense? This is really complicated,
Alec,
and it took a really long time to figure this out.
So are we saying that the germ cells because I always thought like the ovary was a separate structure where you have these cells which eventually become the germ cells go and develop.
Go into the ovary, that is correct. But the development of the ovary beyond just like the tiny little sac that like the germ cells migrate to, in order to develop like a full ovary or like a full testis, you need actual like working germ cells there.
Oh, okay.
Does that make sense?
That makes sense.
So like in other words, the ovary, like the structure that was the ovary before the germ cells got there, cannot develop into a full ovary without having germ cells.
Okay.
Because they've done studies where they prevent germ cells from migrating to, it's called the gonadal bridge, but they prevent it from migrating to the what would become the ovary, and you don't develop like full ovaries. You get a streak ovary.
Okay.
So one very tantalizing mechanism is that, at least according to these articles from the 1960s, is that you don't have migration of germ cells, or sorry, you don't have development of enough germ cells to develop the ovary. And you don't have... Go ahead.
So how did that tie in with the missing X?
Great question. Exactly. So that's what I'm going to talk about next. So if I have a 45XO germ cell, when it divides, I'm going to get a 45XO progeny, right? That's not viable. So I'm not going to get 46XX. The question really becomes, why would you're saying, why would you need 46XX when somatic cells do fine with 45XO?
Yeah, I guess.
Yeah. Great question. I had that exact same question. So I was like, wait a minute, that doesn't make any sense. Their skin cells have 45XO. Like, why can't their germ cells? Doesn't make any sense. And this actually gets back to what Liz was asking. So the general idea, let me see if I can, I don't remember which, oh, actually, can I answer that question in like 20 seconds?
Yeah.
So I just want to make clear the similarities between the lack of ovarian germ cells in Turner patients and the lack of seeds in bananas. Or can someone sort of make that connection in a very big
I guess it's not, so it's not incompatible with life, but it is incompatible with fertility.
Yeah. Or in other words, in both cases, ovarian germ cells and thus development of the ovaries and seeds in the case of bananas, you need a full complement of chromosomes.
Yes.
If I don't have a full complement of chromosomes, I won't develop seeds or ovarian germ cells. Yeah, in a very big picture sense. Okay, so let's talk about Barr bodies, and this will answer your question, Lindsay. So this is exactly what Lindsay asked, right? Why might having an irregular number of sex chromosomes lead to cell death in germ cells, right? Because the same thing happens in Klinefelter, right? They also get the equivalent of streak gonads, right? They have tiny testes, and they get like pilynization of the seminiferous tubules, and right, like they just don't develop properly. So what about having an abnormal number of sex chromosomes might lead to cell death in the germ cells? So first of all, let's talk about Barr bodies, because Liz sort of brought those up. She alluded to them earlier. So what exactly is a Barr body? Come on, guys.
Inactivated X chromosome.
Perfect. It's just the inactivated X chromosome in somatic cells. Okay. So Barr bodies, in other words, are only found in somatic cells. I did not know this until yesterday. Barr bodies are not found, in other words, in germ cells. So in other words, a germ cell, if it has two X chromosomes, both of those X chromosomes are going to be active, because you don't inactivate one of them. Why might we want to inactivate an X chromosome in the first place?
It has to do with it that Y chromosome only has like way less protein coding gene compared to the X chromosomes. So you kind of have to like create a level playing field for both X and Y chromosomes. So majority of the X chromosome has to be inactivated.
Yeah, exactly. So for all the females in this discussion, right, if you didn't inactivate your other X chromosome in your somatic cells, you would have essentially double the amount of sex chromosome proteins that the guys do, right? Because as Yishwen pointed out, there's basically like one gene on the Y chromosome that matters, and it only matters for development of the testes. It basically contributes nothing to the like adult organism, at least that we know of. In general, aneuploidy, right? So not a normal number of chromosomes leads to death in general, right? So like, we think of like, trisomy 13 or trisomy 18 or trisomy 21 as being really, really bad, but they're actually like, those are actually the least bad of all the trisomies. Those are the most mild, even though we think of Edwards House as being really, really bad, because all the other ones are just not compatible with life, right? And so again, if you think about it, having an abnormal amount or having a differing amount of gene product leads to very bad problems with development and oftentimes death, right? So it doesn't make sense then that women would have twice the amount as men, or men would have half the amount of women, right? Because one of the two would have horrible developmental problems, and you can make jokes about that if you want, but right, like from a developmental standpoint, there would be huge problems with that, right? So we have to inactivate the X chromosome in somatic cells in women in order to, as Yishwan pointed out, to have a level playing field. So that if you look at the amount of X proteins, like X-linked proteins in women versus men, it should be about the same. Does that make sense? So silence makes me nervous because silence can mean that you guys have no idea, but are too...
Could you run that by us again, Alec?
Please. Yes, absolutely. What specifically?
Thank you. I guess just that explanation. I'm trying to let it sink in, the whole level playing field concept.
Okay, so let's think about it this way. If, in general, let's say that I had 3 chromosome 3s. Right? So normally I should only have 2, right? But if at chromosome 3, let's say I had actually 3 copies of chromosome 3. What's going to happen to that developing embryo? Chris, what's going to happen?
Trisomy?
Yeah, trisomy 3.
Uh-huh.
What's going to happen?
It would be non-viable.
It's going to abort. Yeah, it's going to be non-viable, right? Why? Why is it going to be non-viable?
Because of an uneven chromosome set or chromosome number?
Yeah, but I mean, think about it. Like you have 50% more gene product at chromosome 3. I mean, our cells are these well-honed, like super well-oiled machines that rely on having a precise amount of stuff when you expect it to be, right? It's about having not too much and not too little when you like pre-signaling stuff, for example. If I change the amount grossly of, an entire chromosome, I'm going to mess up a lot of different things. Does that make sense? So the big picture idea is if I have too much or too little of genes, it is bad for cells. Is everyone on board with that? If I have too much of a gene or too little of a gene, as the white cell should have, it is bad. Does that make sense?
Alec, are you saying that trisomy 13, 18, 21 are the only ones that are actually viable and that them are viable, but it's not all that bad?
No, they're awful. Trisomy 13, 18, and 21 are awful.
But they're the only ones that are viable.
Yeah, which means the other ones are just that much worse.
Okay.
I mean, I'm making the point that we think of trisomy 13, 18, and 21 as being really bad. A lot of people elect to, again, ethics aside, like a lot of people would elect to abort those sorts of, if they knew that was going to happen, because they think of it as such a bad thing. Those on the scale of trisomies, those are actually not that bad, because most trisomies aren't even compatible with life. Have you ever heard of trisomy 1? No, because they never survived to birth.
Alec,
Yeah.
how do we link their chromosomal dysfunction with their phenotypes, like for trisomy 13?
That I cannot tell you. That is because again, you're talking about huge numbers of genes on each chromosome. That is way beyond what I think. There are some questions to which I do not know the answer, but that I'm sure are known. So I can't remember what we were talking about before. Like where exactly in mitosis would you arrest? If you gave someone Christine, I don't know the answer to that, but I'm sure that answer is no. The exact reasons for why they get all of those developmental problems, my guess is that probably is not known, because those are hugely complicated questions.
Okay.
I mean, how would you
You
say?
could sort of connect like the 21 with the Alzheimer's of pre-amyloid being on the 21.
But that's what single protein.
Cancers.
That is a single protein. That's an easy connection, right? Because you're increasing the amount of presenilin. That's an easy connection. But we're talking about, it's like asking, what is the effect of giving someone, or what's the effect of like corticosteroids, right? Glucocorticoid hormones affect, thousands of genes. It's impossible to know, to be able to predict all of those different effects. So it's a great question. I don't think you'll find the answer. That's not one of those things that I would look for. Just because, if you think about how research is done, that would be a really, really difficult experiment. Okay, so big picture, too much or too little of a gene is bad for cells, right? So in order for women to not have too much or too little of, men or women to have too much or too little of a gene, women inactivate one of their X chromosomes so that we all have the same amount of X chromosome per gene, roughly. Does that make sense?
Yes.
That's all I wanted you guys to know. Okay. All right. Germ cells do not have bar bodies. So how can we use this to explain why having an irregular number of sex chromosomes could lead to gonadal atrophy in Turner or Klinefelter patients?
You have a normal amount of protein, which can lead to gonadal atrophy.
Perfect. Yeah. Well, but why gonadal atrophy?
Can you sort of link it to if you have an accumulation of protein, eventually that can cause cell death if you're unable to remove the excess protein?
What cell death though? Cell death in what cells specifically?
The Turley cells?
In the germ cells. The germ cells.
Germ cells.
Germ cells are the ones that need to have an exact number of sex chromosomes. If they don't, and it makes sense that they would need an exact number because they don't inactivate their X's. Right, so females don't inactivate their X chromosomes in their germ cells. In other words, it implies that they need 2 X chromosomes. So if I don't have 2 X chromosomes in my germ cell, I cannot develop properly because I actually need 2. That makes sense. This is cool
Yes.
stuff. It's complicated, but I think it's really cool. Because again, you need germ cells to get proper development of gonads. Okay, this is one of the most complicated topics. I mean, I like it for different reasons, but it's not like cardiology where it's like, you can always bring it back to on principle. Right? So it's complicated. So what questions do you guys have? Because I know that I didn't explain everything perfectly. No, so got to think about it. Okay, so let's talk about Klinefelter. So what's the genotype of Klinefelter?
XXY.
XXY.
So what's the classic gonadal findings in Klinefelter? What am I going to pick on? Natalie, what are the classic gonadal findings in Klinefelter?
Testicular atrophy?
Perfect. Testicular atrophy. Exactly. Which is like the equivalent of a street gonad. Oh, interesting. Okay. So what's one proposed mechanism for how this is likely to occur? What do you think, Natalie? So
Is it because of the extra X?
Okay, so walk me through. So my way, just so you know, Natalie, you haven't been in a lot of these, but my way of knowing if I taught you effectively is if you can give me a reasonable answer when I ask like a more complicated sort of integration question. So if you can't answer it, it's my fault, and I'll try and rectify that by explaining it better.
Okay. I think it's because, so with the extra X, there's an extra amount. So it's not inactivated.
Perfect. I assume so. I don't know. I assume the same is true. And yes, I think you are correct.
And so they have more, I guess, more information that they need.
What do you mean information that they need than they need?
Gene product?
Okay, yeah.
Yeah, I guess.
So the more X gene product. Okay, so Natalie, so what effect is that going to have? So what? How could that lead to testicular atrophy?
That I don't know.
Okay. What's the mechanism of getting testicular atrophy in Turners?
Because of the germ cell.
No. Let Natalie say it.
Oh, I was gonna say that. So there's the extra X. So when there's uneven numbers, it causes cell death.
Cell death of what cells in particular?
Of the germ cells.
Perfect. Germ cells. And why would cell death in germ cells lead to testicular atrophy?
They made the cells in order to form the gonads.
Perfect. Yeah, in order to develop them properly. Very good. Nice. Okay. So now I feel okay about how maybe, despite my explanation, you were still able to come up with a good answer. So it's good. Okay. So again, germ cells, they won't be able to generate 45 XY cells. They'll have an irregular number of X chromosomes. And so the germ cells are going to die. Germ cells die, then I can't get development to the testes. Cool? Awesome. So what's the height of someone with Klinefelter syndrome, Yixuan?
They're really tall.
Really tall? Why? Why are they really tall?
I would think it's because of the extra
I would like to answer this.
Genetic material that someone's supposed to have.
No.
So you have atrophy of the totally or the cells, right? I remember that there's an increased LH and FSH because you're not able to produce enough testosterone You're not, because in bone growth, epithelial plate needs testosterone to mature. So if you have less testosterone, then you won't be able to mature the epithelial plates, which means that over time they will grow taller than those who have normal testosterone levels.
So you use the word mature. If I didn't know what the answer was already, I wouldn't be able to follow what you're saying.
Okay, so
Does it have to do with like growth hormone?
Let's let Finn explain it.
Okay, so the bone, right? Epithelial plates. You need testosterone and estrogen to basically, when you have to fuse the end of the bone to the middle part of the bone, right? If you do that, you won't be able to grow.
In other words, you're talking about closure of the growth plates.
Yes, the closure of the growth plates. That's what I'm doing, and it's dependent on the amount, either estrogen or testosterone, whether male or female. So if you have atrophy of the gonads, you basically, or for males, like you have decreased testosterone, right? Testosterone is produced by Leydig cells. So if you have less of that, you're going to have like in the tubuloinfundibular system, you can have an increase of LH and FSH in order to rectify. But since you don't have the cells in the first place, you're always going to have a constant increased LH and FSH.
So the LH and the FSH, I think, is a distractor. I don't think you have to invoke that to talk about why.
Oh, okay, right. Because you have gonadal atrophy, you have less testosterone, and because testosterone is needed to close the F plates in the bone, if you don't have that, you're not able to, so you can get a taller patient.
Exactly. In other words, perfect. That was great. Okay. So in other words,
Sorry, can you repeat it?
Yeah, I'll explain. So you get testicular atrophy, since as we had pointed out, if you don't have a normal number of sex chromosomes, you're going to have germ cell death. Germ cell death should lead to testicular atrophy. So I'm not going to make testosterone, at least in a large amount. So if I don't make testosterone, remember the epiphyseal growth plates close during puberty because of sex hormones. Let me repeat that. This is really, really important. This is probably the most important, that and the fact that Klinefelter people are tall. But this is the most important thing that I'm going to say on this slide. Growth plates close because of estrogen and testosterone. If I were to give my daughter right now estrogen, she would end up being really, really short ultimately because I would literally close her growth plates. Okay. So it's the reverse in this case. In the case of Klinefelter, I don't have testosterone, which means I don't get closure of my growth plates. Because you and I, we all have growth hormone in our bodies now. It's not causing us to grow taller because our growth plates have already fused. This is why most of us are the same height that we were in high school, once we had delayed puberty. So the reason is because, again, puberty leads to a surge in sex hormones, so estrogen or testosterone. The estrogen and testosterone causes closure of the growth plates, which means we can no longer grow longitudinally, right? We can no longer grow taller. Make sense? So Klinefelters is the opposite. They never get closure of their growth plates because they never get that boost, that jump in testosterone because their testicles atrophied because they didn't have the correct number of sex chromosomes. Isn't that awesome?
Yes, it's really cool.
Yeah, it's nice.
Because they're really, really tall because they never get growth plate closure. So I have some bonus questions. So what are the effects of thyroid hormone on growth? Because this comes up sometimes in stuff.
I think thyroid hormone is supposed to increase the IGF-1 in liver.
Yeah, and it doesn't cause growth hormone, right? Growth hormone causes IGF to go up. So thyroid hormone up, growth hormone up, growth up. Okay. How about, why do we get a growth spurt during puberty, right? Because it seems odd, right? Because like puberty is when I grew the most.
Yeah, because there's a difference between growth hormone and testosterone and estrogen. Both of them can increase the growth at the epithelial plates, but testosterone and estrogen has a closure effect happening after a while. Versus growth hormone.
So I didn't know this, but apparently testosterone and estrogen actually increase growth hormone. I didn't know that until I.
Because before your, is it because like before you grow, before your puberty, your thalamus, hypothalamus kind of get inhibited.
Or what?
There's constant inhibition from your hypothalamus to your pituitary gland.
That inhibits what?
That inhibits growth hormone.
Oh, no. I don't think so. I mean, maybe. Okay. So you're saying there's a growth hormone surge during puberty?
Yeah.
Maybe. But I mean, again, that would make sense because testosterone and estrogen also cause growth hormone increase. So that may be possible. But again, you grow tall. So what's the difference between acromegaly and gigantism? MJ?
Depends on the growth plate.
MJ, what do you think?
Acromegaly is kind of like the person has already been adult, so the height cannot be increased but the hand or the feet or the face bone still grow. And gigantism is kind of like everything is still going to.
Why? What mechanistically allows for gigantism to occur? Because the mechanism's the same, right? It's growth hormone increase. So why, MJ?
Cannot think about it.
Sherry, what do you think?
I think in acromegaly, of course, we have increased growth hormone, but it happens after the growth plates, like the epiphyseal growth place has been closed off, and that's why the person gets growth, but laterally. That's why we can see that they have the wider like face, wider hands.
Yeah, perfect.
And in gigantism, we see that this occurs before the closure of this growth plates.
Perfect. Exactly. Yeah. So it's sort of like gigantism's like an accelerated process of Klinefelters, right? Because Klinefelters, they don't get accelerated growth, and in fact, you would expect that actually they wouldn't even be necessarily that much taller than their peers in high school. You'd actually think that they'd be shorter than their peers in high school because they will not get that growth spurt because they're not going to get that boost in testosterone. So they're not going to get that growth spurt. However, whereas all their friends are going to stop growing in high school, they're going to keep growing because their growth plates never fused because they had atrophied testicles that didn't produce testosterone. That was good. That was very good.
Alec, I have a question.
Please.
Regarding to Klinefelter patients.
Yeah.
If they know that they have this disease and they're going to get taller because of this, of course, the problem they have that their epiphyseal growth, bones do not close off because of testosterone. If we give them testosterone shots, is it going to help them to close them?
Yeah, presumably. Yeah.
Okay, great. Thank you.
Yeah. I don't know that. I mean, like, if you told me as like a high school boy, hey, I've got this thing that will like stop you from growing taller than your friends. Do you want to take it? I don't know that I would use.
Yeah, but these are abnormally tall because I have a symptoms.
Yeah. Okay. So maybe I would maybe I would wait a little bit, but yeah, I see your point. Yeah. I was somewhat in jest, but yeah. Okay. So how about what's the ultimate height of someone with precocious puberty, Lindsay? What do you think if someone were to undergo precocious puberty, meaning like they get puberty before the normal age? What's their height going to be?
Short.
They're going to be short. Okay, why?
Because of the lack of testosterone and estrogen.
What do you mean lack of testosterone and estrogen?
The precocious puberty, isn't that early puberty?
Uh-huh.
Other way, I guess, it's
You'll
because
get
of
more
increase of
estrogen,
fat.
testosterone.
Yeah, yeah, you'll get it early.
Growth plates will close.
Perfect.
Okay, I see.
Yeah. So it's kind of weird, right? So they ultimately are short, but this is what they call like the tallest kid in the elementary school, but shortest kid in high school thing, phenomenon, right? You may even know people like this, but the idea is that, remember, testosterone and estrogen cause an increase in growth hormone. So you will get growth early. You'll get your growth spurt really early. The problem is that you end up having your growth plates are going to fuse that much sooner. And so all of those years in which you could have had just normal growth with like just having growth hormone is not going to happen. I have wondered, although this is unconfirmed, so this is just speculation, but it is well established that girls go through puberty and have their growth spurts sooner than boys. I think we all remember in like middle school and high school where like your friends, like these girls like now become like towering over you, and well, as guys at least. For girls, you may remember towering over the guys and, developing like so much sooner and like undergoing puberty sooner. Yeah. But ultimately, girls end up as shorter. I have wondered sometimes if maybe it's because they undergo their growth spurt sooner.
Yeah, I guess because when guys grow, they already reach a minimum height and then the growth spurt begins.
Yeah, exactly. Like in other words, so you can think about it as the longer you have before puberty, the more time you'll have to like grow with just growth hormone, but not have your growth plates used. So I don't know. I mean, again, I'm sure there are other things at play. And if you ever ask like a geneticist, they would say it's multifactorial. I guarantee that would be their answer. But I don't know. Like, it's an interesting thought. And it also makes me wonder, like, so if I could have just delayed puberty, like, would that have made me taller? Right. These are interesting questions to think about. Maybe not productive, but interesting. Cool?
I'm cool.
Isn't this awesome? Don't you guys love this stuff? This is what gets me up in the morning. So anyways. Okay. But wait. If Klinefelter men are tall, why are Turner women so short? Was any of you guys wondering this? Because you could apply the same thing to Turners, right? But you would expect that Turner women would be really tall, but they're not. So the question is why? So this also comes from an article from the 1960s. But apparently there's a Hox gene. So Hox genes are something you definitely need to understand for step one, or at least know about. On the short arm of the missing X chromosome in Turner, apparently it's one of those things that you need 2 copies of in order to get normal height. So presumably if they call it the Shox gene, short Hox gene. Apparently, presumably if you had this gene, then they would also be tall. But because you lack it, they're short. I thought that was interesting. Because again, you can't use this for everything. But again, there's a lot of stuff that you can understand from this, right? Because you'll see, this is the reason why, for example, what's the treatment for, this is not the presentation, but what's the treatment for precocious puberty? What are you supposed to do in precocious puberty? Do you guys know? This is a good application question. So again, these are the kinds of questions, they will ask this kind of question. This does come up in step 1 and step 2. But not only that, but the kind of question is what they're going to ask you, meaning, can you apply it to a novel context? They're not just going to ask you to regurgitate information. They're going to say, okay, Finn, you know this fact, but can you apply it to a novel context if I kind of change this setting?
Is there a difference
Do you give medication that can...
Hold on, let Finn talk.
Is there a difference between one that is, for instance, precocious puberty caused by a cancer versus precocious puberty that's idiopathic?
Oh, I see.
Puberty?
Well, so precocious puberty in the sense of I have too much sex hormone.
I mean, can you we're sort
You
of
give
use
medication that opposes... Yeah, give medication that opposes the action of the sex hormones.
No, although you could imagine that would be possible, but that's actually not what you do.
Can you use, like for instance, leuprolide? You can basically, you use like constant application of leuprolide, which is a GnRH agonist, and decrease the amount of estrogen or something like that.
Very good. Don't say there was something or that. It was a fantastic answer until you said or something like that.
Oh, yeah. Okay. I removed the something like that from my answer and make it an excellent answer.
Perfect. Well, that was great. So where did you learn about leuprolide?
I don't know. I just went through that like 2 months ago, I think. Like when I was going over reproductive.
So does that make sense? So in other words, leuprolide is what you would give them. So you give them leuprolide in order to suppress. So leuprolide is a GnRH agonist. So it's one of those weird things. So GnRH, what does that stand for?
Gonadotropin hormone.
Gonadotropin release
So
hormone.
in other words, it causes release of LH and FSH, except that if you give it continuously, it does the opposite effect. It actually suppresses LH.
It can be used as a contraceptive too.
Yeah, you can use it as a contraceptive. There's a number of applications of it. It's used basically anytime you want to suppress hormones. So instead of giving like an antagonist, you actually just suppress like releasing the hormone in the first place. So things like prostate cancer that's testosterone dependent, you can give leuprolide, right? So you suppress. I mean, you will do this in clinical practice. You give it to suppress testosterone, so you don't promote growth of the prostate cancer. You can give it. I guess you can use it as a contraceptive. I haven't seen that used that often. Yeah.
We also give spironolactone because it inhibits testosterone.
That is true. Yes, that is true. But in this case specifically, I think you actually just give like leuprolide. You will give it to suppress the testosterone in the case of precocious puberties. Because again, what you are trying to do is you're trying to avoid getting premature fusion of the epithelial growth plates.
Mm-hmm.
Isn't that cool? I love this stuff.
I like one mechanism I came across a while ago, which for leuprolide was it's the constant bathing of these cells in the pituitary with GnRH analog. So they'll downregulate their GnRH receptor and they become less responsive. So then they don't secrete FSH-LH.
Oh, interesting. Oh, that would make sense. You see, you're talking about the mechanism of how it works. That's cool.
Yeah.
That would make a lot of sense. I had never thought of that, and I'd never heard that. Where did you learn that?
I think I read it just like I was looking up this repro stuff and I was studying repro like a couple months ago.
Yeah, that's cool. Does that make sense, guys? So, in other words, like you're down-regulating the GnRH receptor, so like you won't respond to GnRH. Whereas if you give it, because the flip side is if you give it in a pulsatile fashion, it will release LH and FSH. But in that case, it makes sense because you wouldn't, I guess you're not giving it over a long enough period of time to actually cause downregulation. Interesting. That's cool. All right, let's talk about some clinical vignettes because this is like the ultimate way in which we can apply it. So again, I structure all of these the same way. I have clinical integration and application questions. They're going to force you to apply it in a way that's similar to you might apply it on your exam, but also because it's a good way to test yourself to make sure you understand it. Because if you can answer these questions, it means you understand it, right? It means you don't have to sit there and memorize and go through these like pathways. But then ultimately, I'm trying to push you to be able to apply it to a clinical vignette. So that's what I want to do next. So who can walk me through sentence number 1? Let's go with Liz. What do you think?
Okay. A 17-year-old girl is brought to the physician because she never had her period. So it's the opposite of precocious puberty in this case, because generally girls hit puberty around 13, I think. What do you want me to say for the sentence? Like, are there any specific?
So in a general sense, it's what's your interpretation, but
okay.
So like, what do you get?
So
what do you get out of this? What are they trying to tell you? What are they communicating to you with the sentence?
she has some sort of abnormality in her reproductive system.
Okay.
Maybe she has a hormonal imbalance that's causing.
Okay, so when you see this question on your test, that's not what I want you to get. But you're only in first years. I wouldn't have known this at your stage. So I'm being a little mean to you and putting you on the spot, but I'm hoping that
That's
you
okay.
can remember this. Who wants to give this a shot? Who wants to tell me exactly what you should get out of this for a sentence and how that's going to change the way that you approach the rest of it?
Yeah, I really haven't. I've been just studying with her stuff. I didn't really practice the method yet. Well, let me try. A 17-year-old is brought to the physician because she has never had a period. 17 years old means that she's young and she's having this problem. And where you're thinking about not having a period, you think about there's primary causes of amenorrhea and there's secondary causes of amenorrhea. Right? Like what Liz said, it could be a hormonal issue, like you think about prolactin, maybe PSH, or you think it's a genetic.
Which it is right now.
Right, I do. Yeah, I do.
Primary is secondary.
It's primary. It's young, 17 years old.
No. That's not the difference between primary and secondary. Who can define the difference between primary and secondary amenorrhea?
The lack of organs is the primary.
No,
it's not.
No.
Absence of menses.
Secondary should be secondary to other causes such as after hysterectomy.
No. Manu, what were you saying?
I was just saying like absence of menses, even her first menses by age 16.
Perfect. Good. So primary amenorrhea has a very specific definition. It is you have never had a period ever by 16. There's some secondary things like I think it's like if you have like secondary sexual like characteristics, but really it's just you've never. Primary in a big picture sense means you've never had a period ever.
Oh, nice.
Secondary amenorrhea means I had periods at one point, but then I stopped.
Oh, right.
Right. So secondary amenorrhea is like, it doesn't necessarily mean you lack an organ or something like that. Like secondary amenorrhea is like pregnancy, right? Pregnancy is a cause of secondary amenorrhea.
Or hyperlactin levels.
Yeah, I mean, there's a lot of causes, but the differential is very, 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 very different for primary versus secondary. And so, Liz, that was what I wanted you to get out of this first sentence, right? When you read a question, when you read something like this, so if a woman comes in and has never had a period, it's a very different thought process than if they come in and they've had periods before, but then they stopped.
Oh, I see.
All right. Yeah, that makes sense.
Okay. That is what they want you to get from this first sentence. That's the only thing that they want you to get. And as Manu said, it should be by 16. Physical exam demonstrates no breast bud development and genitalia with sparse pubic hair. Chris, do you want to walk us through, like, what are we supposed to get from this?
Okay, so PE has no best breast bud development, so Tanner stage 1 for the breast. I'm thinking that's kind of like a shield chest. I'm thinking Turner's. I'm still not sure.
Okay,
As far as pubic
why
hair,
would you
really earn.
What is the no breast bud development and sparse pubic hair over the genitalia tell you? So again, you went with kind of like a buzzword sort of thing, but I'm asking you, like, how can you think more deeply about this?
If we're thinking about Turner's, she doesn't have enough genetic material because of the X, just the one X chromosome, and she wouldn't be able to undergo puberty. Is that too much of a jump?
That's
Should I go
great.
into
No,
it further?
because now you're giving me a mechanism, so that's fantastic, right? I mean, we may be wrong. We may be wrong when we come up with these mechanisms, but at least you're connecting things and making sense of it. So keep going. Let's say, for argument's sake, that she has Turner syndrome. How could you explain all of the things that we're seeing here from that presumptive diagnosis?
Okay, so if I'm thinking Turner's, then the chromosomal makeup would be XO, just the one X chromosome. Then that would give me streak ovaries because I don't have enough genetic material to have real ovaries, and I wouldn't be able to undergo puberty, hence the no breast buds.
Why
no
would I not
pubic-
be able to undergo puberty? What specifically would prevent me from undergoing puberty?
If I don't have ovaries and I don't have estrogen, then I can't get all those secondary sex characteristics, and I also wouldn't be able to have my period.
Perfect. Exactly. Very good. Yeah, exactly. Secondary sex characteristics like
breasts and pubic hair.
Perfect. Exactly. Well done. Well done. Did everyone get that?
Yes, that was nice. Thanks.
Awesome. That was nice.
That was very good. And I think that pretty much answered all the questions I had. Verbal and motor development or prefer age. What is that supposed to tell us?
It excludes other genetic conditions that could affect her, like, mentally and motor states.
Yeah, I can't think of any, but yeah, sure. Okay, so we said that. So what do you guys think the diagnosis is?
Turner's.
Yeah, I think Chris made a pretty convincing argument for Turner syndrome. So who can explain to me specifically what's the reason for her lack of periods? Who wants to give me a little bit more detailed mechanism than Chris gave before? Hers was good, and for our purposes was more than enough, but I want you guys to be a little bit more specific in this one.
Sure. So basically, estrogen builds up the endometrial cells, right? Endometrial lining of the uterus. And the thing here,
Phase.
progesterone
During what phase?
vascularizes. A follicular stage.
Perfect.
I guess.
During the follicular phase, we got estrogen that can build up the lining in the endometrium.
Right.
I'm with you so far.
Right. So the granulosa cells are the ones that produce the estrogen, right? Over time, endometrial cells, build up, but eventually they become vascularized with progesterone. This happens after the ovulation, right? You have the corpus luteum. The corpus luteum is the is the material that's left over after the secondary oocyte has been released, right? So that structure produces progesterone, and progesterone vascularizes the endometrial cells. And after a period of time, when you slough off because it's vascularized, you get a period. But in this case,
why would you slough off? What caused the slough off?
Okay, so you have so I guess in the beginning you have, I'm not gonna say that. I just remembered. HCG is the one that keeps the corpus luteum alive, right? But so if it's not fertilized, the corpus luteum eventually involutes. If the secondary oocyte, which is arrested at meiosis 2 at metaphase, it's not fertilized, can't go on, and you won't be able to make the syncytial blast, right? Which is after you make the zygote, in order to keep the corpus luteum going, which means that you won't be able to produce progesterone. Progesterone is progestation. So if you don't have that, eventually the sloughing or the endometrial layer will involute, right? It will slough off, and because it's vascularized, you're going to get the bleeding.
Very good. Vin, I am impressed. Where did you learn that? Just by on your own?
I learned that months ago.
Very good. That's really good. It's luteum. Yeah, not luteum.
Oh yeah, luteum. But I'll be the person who I'll mispronounce.
Yeah, no, but that was really good. Did people follow that? So if you watched and understood the previous lecture that I sent you guys, the link that I sent you guys on sexual development and like menses, that should have made sense to you, hopefully. If you didn't, it may not have. You may not have had time.
Right. With the streak ovaries, you won't produce the estrogen, right?
Yeah, you just
so
don't-
you won't have the period.
Very good. Nice. Does that who would like clarification on what Vin just said? Because he went pretty fast. He was pretty thorough, but it was fast.
Can I get a more succinct version? Yeah, please.
Yeah. So in a very big picture sense, so obviously you need to ovulate in order to get periods, right? She's not ovulating, so she doesn't get periods, right? Because she doesn't have ovaries. She doesn't have eggs. She doesn't have germ cells. I don't want to go through again every step of like the menstrual cycle because we went over that.
I think I can give the succinct version.
No, because we've been over that before. Is that what you wanted to go over? The menstrual cycle?
Oh, it's okay. I'm good with what was just stated.
Okay. I would just recommend that you go through the other PowerPoint about the menstrual cycle because we talked about that pretty extensively. So that was very good. Nice. Well done. And so to make it very clear, the reason for her abnormal sexual development, so meaning no breast bud development and no pubic hair, is she doesn't have ovaries, or functional ovaries. So she doesn't have follicles. So she doesn't have granulosa cells. So she doesn't have estrogen release. So no estrogen means estrogen is what allows you to develop the secondary sexual characteristics in women. So she doesn't have the estrogen. So she's not going to develop secondary sexual characteristics. Cool. Would she have a uterus? And why or why not? Vin says yes. Okay, so why?
I think it just has to do with the ovary development. I don't have any other idea other than that. I just know that we have a uterus.
So you're doing the job, but you clearly didn't watch the lecture that I asked you to watch.
No, I didn't.
We talked about that. So for someone who watched that lecture, who can tell me or was there for it?
Is it because she can still develop like the Müllerian part?
Yeah.
Müllerian duct?
Yeah, exactly. Why would she develop her Müllerian ducts?
Because she doesn't express the Y chromosome that doesn't have the
the MIF.
Yeah, exactly. She doesn't have
Müllerian inhibiting factor.
with MIF
Yeah.
or MIH or whatever acronym you want to use. Yeah, exactly. So you don't necessarily need estrogen in order to. You do not need estrogen to develop uterus. You just need to have a lack of MIS. So she has ovaries. She doesn't have testes. She doesn't have Sertoli cells. So she doesn't have something that's making MIS. Perfect. Very good. So this is like my favorite question of all time. Like my favorite sentence all time. I'm only going to give you like one sentence. Because like in step 1 or step 2, they're going to give you a lot more information than this. But this is literally the only information that you need. You can answer this question simply from the first sentence. And that is all I'm going to give you. So who wants to have the challenge of explaining exactly what this sentence means and have the chance of being like a rock star? Because this is like hard, but I think you guys should be capable of doing this. Oh, my hope is that you will be capable of doing this.
Alec, is that the woman who's having trouble getting up or the son?
The woman is having trouble.
Oh, okay.
The son, of course, is going to have trouble.
Alec, is this one X-linked autosomal dominant case?
No, it's a normal Duchenne's, meaning it's X-linked recessive.
Okay.
Great.
Okay, can I try?
So someone says, "Can I try?" Who is that?
I would like to give it a try. Oh, you said, okay, go ahead.
Go ahead.
Yeah, I'm not sure. Okay, anyway, so a 26-year-old woman with a son with Duchenne muscular dystrophy now has difficulty standing from a seated position. So Duchenne muscular dystrophy is X-linked recessive, which means that the mother has to be a carrier.
Okay, so that is good. Why? How do you know that she has to be a carrier?
Because the son is showing the manifestation of the disease. So I don't know, X-linked recessive is normally the mom is the carrier and it pass on to son.
So you're saying that without much conviction, which means that it kind of sounds like you haven't worked through the mechanism of why that would be true. Well, you want to explain to me why that the mom would have to be the carrier? That is the important thing. That is one of the most important things that I want you to understand right now.
Can I try it?
Yeah, go ahead.
In this case, I think dystrophin first is a protein that in this particular case, Duchenne muscular dystrophy has been deleted. This particular gene, this particular protein is produced by this particular gene, which this gene is on the X chromosome.
Perfect. So it's X-linked.
So it's X, that's why it's X-linked. So for the boys, they have one X
and then the other one is Y. So they do not have anything to compensate on that. And that's why they get the whole force of the disease. But for the woman, because she has another X, so it can compensate for the one that is the gene is missing.
Good. So what you're pointing out is the mechanism, the general reason why for X-linked recessive things, in most cases, you will see it expressed in boys.
Yes, because the boys just have one X.
As opposed to women who, as we said before, have 2 X chromosomes, but they inactivate one of them to form a bar body.
Yes.
Perfect. Okay, good. That doesn't explain it though. So the question that we asked was, why does the woman have to be a carrier if their son has an X-linked recessive disease? Why does the woman have to be a carrier?
She's presenting with problems now at 26 years old. If she was not a carrier, she would be presenting much earlier.
But that's assuming maybe it's something else. I don't know. But no, I'm asking you, there's a very good reason. Come on, you guys. You guys should know this. Why does the woman have to be the carrier if the son... Because what?
Because the son, it's XY, right? The Y comes from the father.
Perfect.
The X.
Exactly. Perfect. Yeah. My X, I know who my X chromosome came from. It was not my father. It has to come from the mom because I got my Y chromosome from my dad. You guys should definitely know this. You guys should definitely be able to apply this. I don't mean this in like a punitive way, but like this is something that they expect you to know on your test. And so this is why I love this sentence, because there's so much rich information that's like 95, 99% of people are just going to miss. Okay. So we know that the mother must be a carrier. If the son has an X-linked recessive disease, the X has to have come from the mom because the son doesn't get the X from the dad. Does that make sense? If it doesn't, we should talk about that again, because this is one of the most important points on the slide.
Yep.
Yeah,
that makes sense.
Perfect. Great. Okay. So now, how would you interpret this first sentence? Because it's very different, right? Now that we know that the woman is a carrier, it's a very different interpretation. What do you think? Let's give it a shot. Let's be brave and learn a lot.
Okay, yeah, Chris, go ahead.
Oh, Chris, go ahead.
Oh, me?
Yeah.
Okay. So a 26-year-old woman with a son who has Duchenne's now has difficulty standing. I'm just going to repeat what I said earlier. So the son has Duchenne, which he inherited from the mother from the X chromosome. Sorry, I don't know what else to add to that. I don't know what the diagnosis is.
I'm thinking like her normal allele wasn't activated.
Oh, cool. Okay.
But again, I want you to interpret this. There's a reason why every single word here has a purpose. You guys have uncovered maybe 50% of it. Manu is starting to get it.
My train of thought previously was the fact that, okay, she's a carrier, so she has one X chromosome which has been affected, right?
Mm-hmm.
And then basically in her body, like she's going to have, if you look at every, like in the big picture sense, her somatic cells, there are going to be some cells that have the active X chromosome, which is normal, and there are going to be some cells which have the active X chromosome, which is defective. So it's kind of like that haploinsufficiency, which is going to present with a milder form of the disease later on in life.
Perfect. Exactly. There are 2 other pieces of information that you guys haven't really talked about that I think are really important. So one is her age.
I have an idea.
Which Mother just alluded to. So the age. So she's 26. So what's significant about the fact that she's 26?
I mean, the typical onset for this disease in boys is 2 to 5 years old.
Yeah,
right?
It's like really young.
Yeah.
Toddler to a little past toddler. Yeah. She's having, and then how about the difficulty standing from a seated position? What's the significance there?
Proximal myopathy.
Yeah, it's proximal myopathy. Yeah, go ahead.
I have a question. So before she was able to stand from a seated position, now she has difficulty standing. Does it have to do with the accumulation of the abnormal gene product also for X over time, and then that causes the proximal myopathy?
The way that you said it was vague enough that yes, I think you can say that that's true.
Okay.
But I mean, yeah, dystrophin is what attaches I think it links your actin to the extracellular skeleton, I believe. But I wouldn't quote me on that.
Alec, I don't think it is, because the way that our friend said it, it reminds me the Huntington syndrome, for instance, or Huntington disease. But this one is a deletion. It depends on where in the gene has been deleted, that actually makes the severity of the disease.
So
If the gene-
so Wikipedia says it's a cytoplasmic protein that connects the cytoskeleton of the muscle fibers to the surrounding extracellular matrix through the cell membrane. That's essentially what I said. I just said it, I think I said it attached to the actin, which I think it does. It's either the actin or the myosin. It's one of the elements of the sarcomere. I just forget which. I'm pretty sure it's the actin though, because it wouldn't really make sense for it to be the sarcomere. Or it wouldn't really make sense for it to be the myosin.
So I guess if we just take a step back and think of the fact that there are going to be some sarcomeres with the correct X chromosome, and then there's going to be some sarcomeres with the defective chromosome. So that in itself will dampen the effects of the disease.
Yeah, perfect. Exactly. So you wouldn't see the accumulated effects until much later. Perfect. Exactly. So what is the mechanism then? So spell it out very clearly. This is one of the most common genetics questions that you're going to get. And it is shocking how many times I see students get this one wrong. And I never want to see you guys get this one wrong, because once you understand the concept, it's actually quite easy. And again, it's always going to be some sort of X-linked recessive thing like this. So it might be Duchenne's, they might give you like any of those like X-linked recessive things. So it could be like hemophilia, it could be, I don't know, something else. But it's going to be something like this. It's going to be woman who's a carrier for something, right? So the son is going to have it, who now has symptoms consistent with it, but at a much later age than you would have expected. But that is the most common presentation. And all of these questions are going to ask you, what is the mechanism? And the mechanism is always the same. So what is the mechanism?
I mean, can we say the fact that it's the inactivation of X chromosome in females?
Yeah, exactly. It is because of the X inactivation. However, remember, most women do not have symptoms ever. Most women should not be symptomatic at all from these things.
True.
So the question is, why is this woman having symptoms? Because that's the whole point of calling someone a carrier, is if they're not symptomatic.
Is it because the inactivation process is in fact random?
So what?
Yeah, as in the reason why she's having it, because it might be that her normal allele that's inactivated in this case, and not the abnormal allele.
Perfect. Yes, exactly. Does everyone understand that? So it's not that her normal allele is always inactivated, but a larger proportion, because normally you'd expect about 50% of the time the normal would be inactivated, about 50% of the time the abnormals, the mutated dystrophin containing X chromosome will be inactivated. Does that make sense? It's about a 50-50 shot. So, however, you could imagine a scenario in which a larger proportion of the muscle fibers had the good X chromosome inactivated. So in other words, if a lot of the muscle fibers had only the bad X, the mutated Duchenne or dystrophin protein, then that could lead to like syndromes. Does that make sense?
Yes.
So Alec, just a quick question. If in fact the inactivation of X chromosomes is random, and let's say there are a bunch of ladies who have sons with Duchenne's muscular dystrophy, could hypothetically half those ladies get late onset Duchenne muscular dystrophy? Just if in fact it's random?
Oh, I see. It's not binary though.
It's not binary.
It's not like every single muscle fiber is like either all of your muscle fibers are going to have it or all of your muscle fibers are not. It's going to be like a mosaic pattern. So in other words,
okay.
Some of the, how do I say this? It's going to be like, it's more like a percentage thing. So like, let's say like if, 50% of the muscle fibers are affected, you're probably not going to see symptoms.
Okay.
But let's say that now like 60 or 70% of the muscle fibers are affected, then you might see symptoms.
Okay, so it's just all about luck, really.
Correct. Yeah. So the answer that is most commonly given is they'll say like unfortunate. What do they call it? It's like they don't use the word unfortunate, but it means essentially unfortunate. Like they say unfortunate X inactivation pattern is the almost always.
Okay. I have a quick question just to like clear this up to
Yeah.
try to get this.
Yeah.
Basically, it's just the fact that there's X inactivation in the cells, but it just depends on which X was inactivated.
Yeah. Okay. Exactly. And when you think about like the development, right? I'm pretty sure that like progenitor cells. So like let's say that a progenitor cell, like a progenitor muscle cell, had the good X inactivated, so the bad X was active. Every single cell that comes from that progenitor cell is going to have that same pattern of X inactivation. So in other words, if that one progenitor cell just happens to have a bad X, have the bad X active and the good X inactivated, then all of the progenitor muscle cells all the progeny muscle cells that come from that progenitor are going to have that same pattern.
But Alec, I just still have difficulty to understand that why to show up until she is 26 years old.
Great question. So when does Becker's? So we said Duchenne's is toddler age. When does Becker's present? Becker's muscular dystrophy.
Teen years, right?
Sorry?
Like in the teenage years or a little bit older?
Like in the 10s, right? Like in the second decade of life. Yeah. So why does that present later than Duchenne's?
It's
the
not
same
a
protein,
deletion.
It's what?
It's not a deletion. It's just merely less dystrophin.
Yeah, exactly. So you still have the protein, it's just truncated, as opposed to you're like lacking the protein. Yeah. Wait, MJ, you're saying why wouldn't you just see it immediately? Why wouldn't you see it at the age that the boy would have it?
Because you suppose that in the muscle, the bad X and the good X are being inactivated, but Y-X does not have
I
that
see. Oh, I see. Because the point is that not every good X is inactivated. Remember, it's going to be some muscles are going to have the good X, some muscles are going to have the bad X. Does that make sense? So if every single muscle fiber had the bad X, I mean, statistically speaking, that wouldn't happen. But let's just say that were possible, then yeah, you would expect them to present at the exact same age as a boy that had it. But now think of a situation in which maybe 30% of the muscles had the good X and 70% of the muscles had the bad X. Would you expect them to present at the exact same time as a boy that had every single muscle fiber have the bad X? Does that clarify, or was that just more confusing?
Alec,
Oh, I just
why
want to make sure
wouldn't
MJ
it be?
follows. Oh, 1 second. MJ, does that make sense?
Yeah.
Okay.
Just when you use it or something happened,
You just
the
wanna like-
symptoms show up, right?
Yeah. So if you think like they can compensate because they still will have muscle fibers that have a good X. And so the muscles themselves still have some function. Even the ones that have the bad X are going to still have some function. Because again, like the kids still, like even kids that have completely, that have like, boys that have it still have some function in the muscles. So there's still some function there.
Makes sense. Thanks.
So you just don't see it totally. Sorry, Yishwan, you were asking?
Yeah, sorry, I just don't get it. Like, why would both Becker and Duchenne, like they manifest around the same time, but Duchenne just milder form?
Becker's is a milder form.
Oh yeah, just Becker the milder form, as in the disease manifestation. Like why don't they manifest the same time?
At the
Is that
same
the
time.
symptoms
That's a good
just
question.
milder?
I don't know enough about dystrophin. I mean, the general answer is the dystrophin protein in Duchenne's has zero function. In Becker's, you could make an argument that there's probably like, who knows, maybe 30% function in the protein. So at least there's like some function. So it'll take longer for you to get like the muscular dystrophy, like the muscles to break down and have like fibrosis. But exactly why molecularly that is, I don't know. That's a great question. That's one of those things that's probably known, and I just don't know the answer, but I personally do not know.
Hey, Alec.
Uh-huh.
Does this have to do with like the concept of penetrance? Like how?
No, this is not the concept of penetrance. This is actually completely different from the concept of penetrance. So what is penetrance?
How severe genetic mutation affects you is what I understand.
No, that is not penetrance. So you're thinking variable expressivity.
Variable expressivity. Okay.
That's actually a good thing to talk about because we still have a little bit of time, and these are questions that come up constantly with students that have trouble with. So let's talk about that. So penetrance versus variable expressivity, or I guess, yeah. So what is penetrance? What does penetrance mean? Can someone give me the definition?
I think penetrance is if you have a mutation, it's the percentage of people with the mutation who end up with the phenotype.
Perfect. Oopsies. If you have the genotype. So in other words, I have a mutation. This is a binary thing, right? So if I have a mutation, this is specifically talking almost exclusively about autosomal dominant disease. Whenever we talk about penetrance, we are in almost every case talking about autosomal dominant stuff. So that means if I have a mutation, so if I have the Marfan's mutation, do I have any sort of phenotype or not? That is penetrance. So if it's 100% penetrant, it means if it's 100% penetrant, what does that mean?
But if you have the mutation, you're going to show the mutation.
Perfect. If I have the mutation, I will show some manifestation on it, physically. It does not tell me the degree to which I will show any manifestation. You can't tell based on penetrance alone whether, like, if it's going to be severe or not. It just says that you're going to have some sort of phenotype. So that's why I say it's binary. It's either yes or no. Do you show any sort of outward findings or not? It doesn't tell you anything about the severity of it. So how about variable expressivity? Variable expressivity. So what does that mean?
Do you show like all manifestation, or is it just some of the manifestation?
Well, the variable expressivity means if I show manifestations, it means that those manifestations will vary between person to person. So for example, for Marfan's is a good example. Some people have the long fingers and some people don't. Some people have aortic dilation, some people don't. Some people are going to have
I was going to say, is Huntington's an example of that? Like the age,
Huntington's
of
also,
onset?
yes, exactly. Huntington's is Huntington. Yeah, Huntington's. So those are a little different because those are also going to show anticipation.
Okay.
Yeah.
Which we can also talk about. So variable expressivity. Let's just make sure that we understand variable expressivity. So if I show phenotype, right? So this is assuming that you show a phenotype, right? So for anyone that has, for which it's penetrant. So if I show a phenotype, the phenotype will vary between people, right? So probably the best example would be like neurofibromatosis, right? Some people get like really bad neurofibromas. Some people might get, pheochromocytoma, right? Some people don't, right? The manifestations of that are going to be different, okay? How about anticipation? What is anticipation? And where do you see that?
Huntington disease.
So what does it mean? And
Like
where do
when
you see it?
your grandfather has Huntington at 70, your father will get it at 50, and you get it at 30.
Perfect.
Yes, earlier.
Yeah,
and
exactly. So a disease gets worse in successive generations. And this is seen almost exclusively in what mechanism of disease or what kind of disease?
Do you try nucleotide?
Trinucleotide repeat
Seen them
disease.
almost exclusively in trinucleotide. I only know of it happening in trinucleotide repeats. I always put in like qualifiers because there's always exceptions in medicine, so I've just learned to expect that. But for your purposes, it is only seen in trinucleotide repeat diseases.
Like Friedreich's syndrome, ataxia or something.
Fragile, stuff like that.
No, Friedreich's. I can't even pronounce it correctly. It's the like.
Friedreich ataxia.
Yeah, Friedreich
ataxia.
How do you pronounce it? Yeah.
But does that make sense?
Friedrich? Yeah. Okay, I'm gonna sound retarded in my clinical system. That's cool.
About so I don't want to get too far afield, but you were asking about penetrance. Was it Lindsay?
And I think you were looking for the words schwannomas with their neurofibromatosis type 2, right?
Yeah.
Or whatever. Yeah.
So, but penetrance.
Alec.
This is not penetrance. This is not referring to penetrance.
Thank you.
Sorry, in other words, the X-linked recessive phenomenon of having like random X inactivation and having an unfortunate sort of pattern of inactivation, that is not penetrance. And that they will show you that as an answer on the test, and that will be wrong. So the answer is always in these cases. Again, so let's be very clear on what the scenario is. It is a woman who's a carrier, and you know that they're a carrier because their son has it. And if their son has it, you know that they must be a carrier, right? If a son has an X-linked recessive disease, you know that they must be a carrier because the X chromosome for the son has to come from the mom, right? So you know that. They're usually going to be older, like this, when they're going to be manifesting symptoms of the disease, whereas they shouldn't because, again, it's X-linked recessive. They should be a carrier. They shouldn't manifest it. So that is the classic setup. And so the take-home message is, in every case that I can think of that I've ever seen on any practice test or any exam or anything, the answer is always some sort of unfortunate pattern of X inactivation. Now that we've talked about this, I hope that you never get this question wrong because it usually shows up at least once every NBME or once every other NBME. It's a very, very common question. And if you understand the genetics, it's actually not that hard. It's actually really easy, really, really easy. It's a free point. Thank you. You guys are going to get any of this. Cool?
Cool.
Perfect.
Just have one follow-up question.
Please.
So just from the principle you said, will this also hold true if we go the other way with regards to X-linked dominant diseases, that the female will have less severe symptoms?
Oh, so to be honest, I don't know of really any X-linked dominant diseases. I know that they exist. I've looked it up before, but I don't know. It is the short answer to your question.
Okay.
I don't know the mechanism of X-linked. Because again, it's hard to tell. Like dominant diseases have like a different mechanism, right? Recessive diseases, it's usually the lack of something, and it's often like a structural protein or like an enzyme that's important. And so like you lack activity in that, and that was why it caused the problem. Dominant diseases, oftentimes it can be like an activating mutation or something. So it's hard to predict. I don't know that you can make such a broad general.
Okay.
Now you know the key concepts that make pediatrics finally make sense. Next, you need the right practice system to turn that understanding into real points. In my UWorld Complete Guide, I'll show you the exact phase-by-phase approach top scorers use to go from knowing peds concepts to crushing their shelf and step 2 with a 260 plus performance.